Good morning and warm welcome to Online Anesthesia. This is a postgraduate teaching program on Zoom platform sponsored by Akola and hosted by Rajesh. It is also aired by Anaesthesia TV. Today we start the critical care series. Two important topics today are the management of acute heart failures by Dr. Sabanayagam, and the second topic is how do I safely ventilate my patient in OT by Dr. T.R. Chandrashekar. Chandrashekar sir has accepted to deliver 3 more topics on mechanical ventilation in the coming weeks. So today's session is coordinated by Dr. Rajesh Jeyaprakash. So over to you, Rajesh sir.
Good morning, sir, and good morning, one and all. Today we are starting with our new voyage, that is into the critical care session in this online anesthesia teaching program. Today we have 2 eminent speakers who are well known all around the world for their excellent way of delivering lectures. The first lecture will be on management of acute heart failure by Dr. Sabanayagam, being called as Sabha sir. He is a clinical lead and senior consultant in multidisciplinary ICU at MGM Health Hospital, Chennai. He got a vast experience in critical care medicine, being trained in India, UK, Ireland, and Australia. And he has an enormous interest in ECMO and adult critical care medicine. And he's a great academician who is an active participant of ISCCM meetings and all. We welcome you, sir, and over to you, sir, to deliver the lecture.
Thank you.
Sabha, sir.
I'll share my screen now.
Yes, sir.
You're able to see my screen?
Yes, sir.
You're able to see. Okay. Right. Good morning, everybody. I'm Dr. Sabha. I'm an intensivist. My base specialty is anesthesia, and most of my practice is intensive care. Almost like 80% I practice intensive care and 20% anesthesia. Thanks for giving me this opportunity to discuss about acute heart failure and the relevant management to acute heart failure. One second, sorry. My slide doesn't seem to be moving. Yeah, it's moving now. Okay. So for the next 1 hour or so, I will be going through the definition of different heart failures, different types of heart failures, how they are being classified. And then once we understand the pathophysiology of heart failure, then we will dwell around how to diagnose heart failure, basically how to classify and then how to diagnose. And then quantification of the problem. Any patient who comes with a problem, you'll have to quantify them so that you get a better understanding of the disease and so that you also treat them better. And finally, the last step would be how to manage them effectively in such a way that you prevent rehospitalization and readmission to the hospital. So that will be our learning objectives for the next 1 hour. Now, the reason we are talking about heart failure is that there are millions and millions of patients in the world who suffer from heart failure, some sort of heart condition which eventually leads to heart failure. And because of this, the financial burden on all parts of the world, whether it is a developed country or a developing country like ours, the financial burden is very high. Now, what this leads to huge amounts of mortality and morbidity. There is data to say that almost 50% of those patients who are diagnosed with heart failure today will die in the next 5 years. And a lot of these patients die because they are treated suboptimally. Then the other bigger problem is when they are treated suboptimally, the risk of rehospitalization. They come to the hospital, get treated, and then go back home because of suboptimal treatment. Within the next few weeks or months, they come back to the hospital with a heart failure again. Now, this leads to rehospitalization and lots of economic, financial burden on the family as well as the medical system. And lastly, these are patients relatively on the elderly age group that we see with heart failure. And they always come in with more than one comorbidity. So which makes the entire situation a little complex to deal with. Okay, let me jump into the definition of heart failure. Technically, it's been defined as the inability of the heart to pump adequate blood into the systemic circulation. Technically, there is no enough blood going, which means there is no enough oxygen going. Now, this has been the traditional definition of heart failure, but that is not it. What we are talking about here, that blood is not flowing forward from the heart, it's called as a forward failure. There is also an entity called as backward failure. Now, the problem is when the heart doesn't receive enough blood, there is congestion on the backside. So technically, we're dealing with the venous system not being able to drain blood into the heart. Now, this leads to increased filling pressures and thereby leads to congestion. Now, if the left heart fails, it's congestion in the lungs. If the right heart fails, the same congestion happens in the systemic veins. So we're talking about congestion in the liver, congestion in the gut, congestion in the kidneys, congestion in the peripheries, peripheral edema, etc. Now, this is called as backward failure. Now, what is forward failure? Technically, the left ventricle or the right ventricle is not able to pump adequately, not able to generate a stroke volume adequately, and thereby the cardiac output is decreased. As a result, there is poor perfusion onto the forward system. Now, this leads to poor oxygenation, and as a result, this is called as a forward failure. So this is just an illustration to what I have just explained before. Technically, you can call heart failure as a right heart failure or a left heart failure. Now, each of this right heart or the left heart can have a forward failure or a backward failure. If a right heart has a backward failure, which means the vena cava, the superior vena cava and the inferior vena cava, which drains blood into the right atrium and right ventricle, does not drain effectively. As a result, there is a vena caval congestion of blood, which leads to congestion of all the organs which drain blood into the vena cava. I'm talking about liver congestion, I'm talking about gut congestion, I'm talking about congestion of the kidneys, I'm talking about ascites and peripheral edema. So technically, a patient who's got a right-sided failure will have congestion all across the body, and as a result, profuse edema or anasarca, that's what we call. Now, the same problem when it happens to the left ventricle or left ventricle backward failure. Technically, what drains blood into the left ventricle? It's the lung. So there is not enough blood that is being able to be drained through the pulmonary veins into the left atrium. Now, as a result, you have congestion in the lungs that leads to pulmonary edema. So a patient with the left ventricular backward failure comes to you with pulmonary edema, which is nothing but breathing difficulty. Now, this is the backward failure for the left and right heart. The forward failure for the left and right heart pumps blood into the left heart technically. So technically, when there is a right ventricular forward failure, there is not enough blood reaching from the RV into the LV. And so LV stroke volume is compromised. The same happens with the left ventricular forward failure also. There is not enough blood going out of the left ventricle. And as a result, there is poor perfusion into the systemic circulation. Now, when the heart starts failing, irrespective of whatever the cause is, the pathophysiology is the same. The most important problem that happens is the heart starts failing. There is a stretch in the heart wall, which leads to the ventricular wall stress. Now, this is nothing but the oxidative stress. And as a result, the oxygen demand increases. But there is not enough oxygen coming. So the inflammation gets worse. And once the inflammation gets worse, there are three important organs which are affected as a collateral damage. One is the endothelium of the blood vessel. The second one is the kidneys per se. And the third thing is there is an extensive venous congestion. So it all starts with the heart and then it spreads to the other three parts, which is the vascular endothelium, venous congestion, and then the renal function. As a compensatory mechanism, what happens is the kidney tries to give the blood back to the heart. So technically, when the left ventricle or the right ventricle fails, there is not enough stroke volume. So the kidney thinks that there is no enough volume and it starts activating the renin-angiotensin-aldosterone system. So as a result, there is sodium and water retention. This sodium and water retention, in fact, leads to increased intravascular volume and then stretches the heart further. Now, this is nothing but a compensatory mechanism for a poor stroke volume. But it can only happen for a certain period of time. The heart, the left ventricle starts stretching for a certain period of time. And beyond that, it leads to an irreversible format called as LV dysfunction or LV failure. Ultimately, this leads to secretion of extensive brain natriuretic peptide, which is a marker of a cardiac failure. Now, some of the causes, which is very closely attached to the mechanism by which it causes failure. For the left side, you can broadly classify a systolic dysfunction or a diastolic dysfunction. Technically, a systolic dysfunction is something which leads to a forward failure. Here, there are two important problems. Either there is an impaired contractility of the left ventricle itself. An impaired contractility of the left ventricle, it's very easy to conceive. It can be a myocardial infarction. It can be just a transient ischemia like an angina, or a chronic volume overload state like a mitral regurgitation or an aortic regurgitation, or a cardiomyopathy, especially the dilated cardiomyopathy, which can be from viral, which can be alcoholic. There are many reasons for people to get a dilated cardiomyopathy. So technically what we are talking about is an impaired contractility of the left ventricle that leads to a systolic dysfunction, and as a result that leads to a post-stroke volume. The other reason for systolic dysfunction is an increased afterload. Now, afterload is an entity against which the ventricle has to contract. To a certain extent, it will be able to push blood against the afterload. But then when it goes beyond a point, the left ventricle has a dysfunction. Now, this can be caused by an uncontrolled hypertension. We are looking at blood pressures beyond 200 of systolic blood pressure here, or in valvular problems like aortic stenosis, where the afterload is so high that the left ventricle is not able to push blood overwhelmingly high afterload. Now, this causes systolic dysfunction. When it goes to the diastolic dysfunction, technically you're looking at a heart which is not compliant. It's not able to accept the blood which is coming into it. This is diastolic dysfunction. So this can be caused by obstruction to left ventricular filling. Technically in mitral stenosis, there is not enough blood coming from the left atrium into the left ventricle. So technically the LV is not filling. The other causes is problems around the heart, like a tamponade or a pericardial constriction, which can be restricting the blood coming into the heart. So the ventricle is not as pliable, it's not as flexible. As a result, it's not stretching enough to receive the blood coming into it. The other possible reasons would be a left ventricular hypertrophy. Just imagine a chronic hypertensive, somebody who goes to the gym regularly and works out vigorously. So the left ventricular hypertrophy is so big that the ventricles become very stiff and causes a diastolic dysfunction. Hypertrophic cardiomyopathy, restrictive cardiomyopathy, even transient ischemia can all lead to diastolic dysfunction. So technically, most of the diastolic dysfunction will lead to what is called as a backward failure. Here, the systolic function is largely preserved. Now, similarly, for the right-sided failure, the causes of right-sided failure are a little different. We can broadly classify them as cardiac causes of right-sided failure and the pulmonary causes of right-sided failure. The cardiac causes, usually the left-sided heart failure, are more common, and over a period of time, if the left-sided heart failure is not treated adequately, the left ventricle dilates, the left atrium dilates secondly, then there is pulmonary venous congestion, there is pulmonary venous hypertension, which is like just a pathophysiology of a left-sided failure. Pulmonary venous congestion, pulmonary arterial hypertension, ultimately it starts affecting the right heart. You end up having tricuspid regurgitation, and then there is right ventricular dysfunction and the right atrial dilatation. So technically it all started on the left side, and then there is the reverse pathophysiology which ultimately affects the right side because there is buildup of pressure backwards. Now, pulmonary stenosis is a condition which can cause right-sided failure, and right ventricular infarction. Now, these are the cardiac reasons why somebody can have a right-sided failure. More commonly, you would see pulmonary causes for right-sided failure. The right ventricle technically has to pump blood into the lungs. When there is a problem in the lungs, then you get the condition called as cor pulmonale. If there is pulmonary embolism or a pulmonary hypertension, like a primary pulmonary hypertension, the right heart finds very difficult to pump blood into the lungs, and as a result, there can be right-sided heart failure. When there is long-standing parenchymal diseases like COPD, interstitial lung diseases, patients who have like chronic infections like tuberculosis, or conditions like ARDS, whatever be the reason for the ARDS, patients go in for a right-sided heart failure. So this is nothing but your popularly known Frank-Starling curve, where the x-axis gives you an idea about the blood volume and thereby the pressure that builds up into the left ventricle. It's nothing but the LVEDP, left ventricular end diastolic pressure. Now, in a normal heart, where you find this point A, this is the curve which depicts the normal heart. As the left ventricular end diastolic volume increases, that is the blood volume increases, automatically the pressure slowly increases. Now, with an increase in pressure, because the ventricle contracts effectively, the stroke volume also increases. That's why you see a curve of this slopiness over here. Now, what happens is in heart failure, as the left ventricular end diastolic volume increases, for the same pressure over here between A and B, now this is a failing heart, the one in the bottom. For the same pressure, the stroke volume is much lesser. And when you try to increase the volume more and more as a result of fluid retention, secondary to the compensatory mechanisms, the kidney tries to compensate, right? With the renin-angiotensin aldosterone system, sodium and water retention, increase in intravascular volume. Now, this left ventricular end diastolic volume and pressure keeps increasing, but that does not reflect on a huge increase in the stroke volume. It has just come from this point to this point. Whereas if it were a normal heart, for an LVEDP of here, your stroke volume would be here. But here, whereas in a failing heart, the left ventricular end diastolic pressure does not contribute much to the increase in stroke volume. This is largely the pathophysiology of the heart failure. Now, this is one reason where you want to introduce inotropic agents so that you increase the contractility and thereby increase the stroke volume. At the same time, you don't want to build up the left ventricular end diastolic volume too much. So you try to decrease the preload. That's what we're talking about. Preload is nothing but the LVEDP. So you decrease the preload, your chances of the heart failing is much lesser. Just an illustration to show you what happens when there is a left-sided heart failure. What are the signs and symptoms that the patients would experience? So technically, left side has a forward failure and a backward failure. When there is a backward failure, usually the blood which drains from the lung through the pulmonary system into the left ventricle starts congesting. So the venous return from the lung decreases. This leads to pulmonary congestion and this leads to alveolar edema. Once there is alveolar edema, it is very difficult to send the oxygen across from the alveoli into the pulmonary system. And as a result, the patient experiences dyspnea, orthopnea, or a paroxysmal nocturnal dyspnea. So technically, you're dealing with a completely wet lung, a pulmonary congestion leading to hypoxia. And these patients typically present with breathing difficulty. So that's pulmonary edema for you, which is the left-sided backward failure. When the same left ventricle goes through a systolic dysfunction or a forward failure, so technically blood is not pumped out of the left ventricle. This can be from an uncontrolled hypertension. This can be from a poorly contractile ventricles for whatever reason. The most common reason would be myocardial ischemia, myocardial infarction. Or if there is a severe aortic stenosis, there is not enough blood leaving the left ventricle into the systemic circulation. This leads to poor oxygenation of the peripheral organs. I'm talking about the vital organs. Poor perfusion of the brain, poor perfusion of the heart, poor perfusion of the liver, kidney, and the peripheries. So appropriately, there will be signs and symptoms which represents the particular organ. If it is poor perfusion of the brain, this patient is delirious, a hypoxic brain, completely confused, oriented and disoriented, irritated and all that. So the brain doesn't get enough oxygen. If it is going to be the heart, you know what it is. Patient will have tachycardia, patient will have hypertension. Now, hypoxia of the peripheries, you have cold, clammy peripheries, your capillary refill time is increased more than 3 seconds, and there is lactate buildup. So your lactates will almost always be more than 2. A poor perfusion of kidneys leads to oliguria, and raise in urea and creatinine. Poor perfusion of the liver can lead to ischemic hepatitis. You have elevated transaminases. So this is the forward failure of the left heart. Similarly, for the right heart, you can have forward and backward failure. Again, what drains into the right heart? When the right heart does not accept enough blood coming from both the superior vena cava as well as the inferior vena cava, there is congestion of the vena cava system. When there is congestion of the vena cava, all the organs which drains into the SVC and IVC, including the brain, the liver, the kidneys, the gut, the peripheries, your limbs, everything gets congested. So there is edema of all these organs because of the increase in hydrostatic pressure. So technically, we are dealing with the peripheral venous congestion. So with liver, there is hepatomegaly that is called as cardiac cirrhosis for a period of time. So renal failure, because of renal congestion, the kidney doesn't function well. So you have oliguria and increased urea. And then there is peripheral edema. You almost always have ascites and bilateral lower lip swelling and all that. So technically, this is the backward failure of the right heart side. But if the forward failure of the right heart, the right heart pumps blood into the lung and from there into the left ventricle. So technically, the left ventricle does not get enough blood. So technically, this represents the forward failure of the LV as well. So inadequate stroke volume, and you have signs of poor perfusion of all the vital organs. So this is exactly the same as the LV forward failure. So these patients can be broadly classified into two categories: whether they have edema or not, whether they are warm or cold. Based on this, there is a combination of this. So this illustration has backward failure or congestion in the x-axis and forward failure or perfusion in the y-axis. Let's assume that this patient has congestion. So when a patient has congestion, there is edema. So we're going to call this patient as wet, whether it's edema of pulmonary edema or peripheral edema. These patients are wet. When there is no edema, we're going to call them dry. Now this belongs to the x-axis. In the y-axis, we're dealing with perfusion. When there is poor end-organ perfusion, cold, clammy peripheries, increased capillary refill time, lactates, and all that, we're going to call them cold. That's why they're called cold, clammy peripheries. When the perfusion is going to be normal, we're going to call them warm. So when you put the cold, warm, and wet, dry into categories, you get 4 combinations. Interestingly, these patients who present with acute heart failure, the most common combination is wet and warm. They present with some sort of edema, either it's a peripheral edema or a pulmonary edema, and they're most of the times warm. And this category amounts to more than 90% of the patients who present with acute heart failure. That is one reason I'm dwelling upon this group. So most of your heart failures who present with an acute heart failure of whatever region to the emergency department or intensive care, they present with wet and warm. They have some sort of an edema, and almost always they are warm. Heart failure, again, a lot of times, we also deal with these patients as part of our patients who come in for some sort of anesthesia or intensive care, whatever. A lot of times they are previously diagnosed to have heart failures. That's why I want to give you this classification of acute and chronic heart failure. So chronic heart failure patients are established heart failure patients. We know that for a period of time, these patients have had some sort of a heart failure. Because of treatment, either they have a very stable period or see that there is a slow but steady deterioration over a period of years. Now, these are chronic heart failure patients. They generally present to your OP or to your pre-op assessment clinic or some sort of procedure. And you have to be very sensitive to identify these patients, because those patients who've been having a slow deterioration in spite of being on treatment are at a very high risk to have a major adverse cardiac event around the perioperative period. Now, those ones are the acute heart failure patients are the ones that you deal with in the intensive care. Either they are new onset acute heart failure for whatever cause that has happened, most commonly an ischemic heart disease, or these are patients who have an acute problem on pre-existing chronic heart failure. And most of the times, these deteriorations are quite rapid. The chronic heart failure patients, those ones who typically present to you during a pre-op assessment clinic, they can be broadly classified into three categories. The first category is, this categorization or classification is based on the ejection fraction. So those ones with a left ventricular ejection fraction of less than 40% are categorized as heart failure with reduced ejection fraction. So they are known to have a reduced ejection fraction, which is less than 40%. And then this MR is mid-range. Heart failure with mid-range ejection fraction. These are the ones with an EF of around 40 to 50% technically. And there is also a category of patients with heart failure who have an LV ejection fraction of greater than 50%, excuse me. So we traditionally had this belief in the past that ejection fraction is one entity which tells you whether there is a heart failure or not. It's not valid anymore. So heart failure can exist with ejection fractions ranging from less than 40% to greater than 50%. Just because your left ventricular ejection fraction is more than 50% doesn't mean that your patient does not have failure. You can have a diastolic dysfunction and as a result, a backward failure. In these patients, diastole is the problem, not the systole. So your ejection fraction is a quantification of your systolic function, not your diastolic function. So you can still have patients with a diastolic heart failure with a normal EF, maybe even 55-60%, but they can still be in failure. If you look at signs and symptoms, they have signs of backward failure. They may come in with pulmonary edema. They may come in with peripheral edema. They may come in with raised BNPs. All these are markers of cardiac failure. You look at the ejection fraction, it can be greater than 50%. So that is one reason this third category has come into play, called as heart failure with preserved ejection fraction. Now, these are the classification for chronic heart failure. And it's very important for you to understand this because these are the patients who present to you for pre-op assessment. And it's important that you are sensitive, that you identify what kind of failure they have. And based on that, your perioperative management can be a lot wiser. Okay. What we are going to dwell around here for the next maybe another half an hour plus is acute heart failure. So usually these patients come into you with a new presentation or worsening of their chronic heart failure. When they present to you, these acute heart failure patients can only present to you in 4 different ways. And these are the 4 different categories. It can be an acute decompensated heart failure. Technically, these are chronic heart failure patients with an acute decompensation. These are most of the times documented chronic heart failure patients. That is the acute decompensated heart failure. The second category of patients are the wet category, acute pulmonary edema. So technically, you deal with the patient who is coming with a breathing difficulty. So this is acute pulmonary edema. And the third category is isolated right ventricular failure. Most of the times, it can be due to ischemia or could be due to a cor pulmonale, secondary to a lung problem, like a pulmonary embolism, where you have an isolated right ventricular failure. And lastly, those patients who present you with a cardiogenic shock, a complete failure of the heart with a very poor perfusion as well as pulmonary edema. Now, the reason the patients with acute heart failure have been categorized into 4 different categories is based on the type of failure, the treatment varies, the prognosis varies as well. And the etiology for these 4 different categories are also different. So it is very important that you identify what kind of presentation these patients with acute heart failure have. So in the acute decompensated heart failure, the most common mechanism is fluid accumulation. And as a result, there is increased ventricular pressures. The left ventricular end diastolic pressure increases. As a result, they are always wet and warm. They are wet because there is a backward failure, there is pulmonary edema. And almost always they're warm because the forward flow is not compromised much. The perfusion is not compromised much. In this category of patients, diuretics plays the major role. Those patients with acute pulmonary edema, the problem is, again, a left ventricular failure, which leads to an increase in the left ventricular end diastolic pressure. And as a result, there is pulmonary congestion. And as a result, there is pulmonary edema. And these patients are almost always wet and warm, very much like the acute decompensated heart failure. And the treatment is diuretics and vasodilators. Isolated right ventricular failure. And again, the most common cause would be a lung-related isolated right ventricular failure. And I will also go into an algorithm going about how to treat these patients. So let me not dwell around the management of these individual failures here. And last category is the cardiogenic shock, where there is a profound systemic hypoperfusion. And these patients are very difficult to treat because they are both wet and cold, which means there is both failure of relating to congestion, whereas there is pulmonary edema or peripheral edema, and also failure of perfusion, where the end organs are not perfused well. Now, when these patients present with an acute heart failure, this is just a standard algorithm on how to work them up. For any patient presenting with any problem to your ICU or emergency department, you go about in a systematic way: history, clinical examination, investigations, and then plan your treatment, right? So the first three are very, very important. So these patients as well, take a careful history, examine them very carefully, and go about investigating them with some of these investigations. An electrocardiogram, pulse oximetry, echocardiogram of the heart, bedside, transthoracic echocardiogram, initial laboratory investigations. I'm talking about investigations like CBC, renal function test, liver function test, and pro-BNPs, chest X-ray, lung ultrasound, and depending on what the patient's history and clinical examination is, whatever specific evaluation you want to have. BNP is a very important test over here because a BNP can technically rule out a cardiac failure if it is within the normal range. So it has become a gold standard for those patients who come in with signs of failure. You do a BNP or an NT-proBNP, and if your BNP values are more than your baseline, your reference values, you can almost always rule in a heart failure. And if it is within the normal range, less than the normal range, you can rule out the heart failure. These are some of the investigations. And these investigations, again, can give you an idea both about the cause of the heart failure as well as the effect of the heart failure. As the cause of the heart failure, the ECG can tell you if there is any ischemic changes. Your echocardiogram can tell you whether there is any mechanical or obstructive changes, whether there is a regional wall motion abnormality, whether there is a tamponade around the heart. All these can be revealed by an echocardiography. And the other investigations like a chest X-ray or a lung ultrasound will give you an idea about the effect. If there is a backward failure, pulmonary edema, if there is going to be a poor perfusion, you can have an altered liver function test, altered renal function test. Your lactates, your APG will give you an idea about the perfusion. And so there are many things that gives you an idea about either the cause of the heart failure or the effect of the heart failure. These are some of the investigations which are regularly done for those patients who present with a heart failure. Iron status, those patients with chronic anemia can present with a heart failure. Thyroid function test will give you an idea whether this patient has got a heart failure secondary to hypo or a hyperthyroidism, because both can cause. D-dimers gives you an idea about the patient presenting with a pulmonary embolism. Procalcitonin. Sepsis is a very close mimicker of heart failure. So you would want to know whether there is any markers of sepsis. Lactates gives you an idea about the end organ perfusion. So all these tests are targeted towards one thing, whether it is a cause or the effect. Now, based on the history, clinical examination, and investigations, you qualify these patients in one of the four categories. The first category is the acute decompensated heart failure. Now, these are patients who typically present with congestion, that is wet. So you have to go about and treat the congestion first. But before that, based on your clinical examination history, you need to understand whether there is hypoperfusion, whether the patient is cold or warm. If the patient has got signs of hypoperfusion, yes, then you need to have a combination of loop diuretics, which is most commonly used loop diuretic in this condition is furosemide. Some people also use torsemide. So a combination of loop diuretic, and because there is also hypoperfusion, that is poor perfusion, in addition to pulmonary edema or congestion, we add an inotrope. So for these patients with both congestion and hypoperfusion, it's a combination of diuretic and inotrope. And then you evaluate the patient. Look at the hypoperfusion and congestion during your evaluation. Then if it continues to be there, then you need to have you have to optimize the medical therapy. Whereas there is no relief of symptoms, your hypoperfusion and congestion is not relieved, then you can go about and add vasopressors to this combination. Now, usually this combination helps, but when this combination of diuretics, inotropes, and vasopressors do not help, then you start thinking about further support. Here, at this point, you have deemed that your pharmacological therapy with the diuretics, with the inotrope, and with the vasopressor like a noradrenaline has not helped. So the next step is going about for a MCS, which is nothing but mechanical circulatory support or mechanical cardiovascular support. And you can also think about renal replacement therapy. Basically, we're talking about dialysis at this point, because idea is to try and get the preload down. So you introduce the diuretic to get the preload down. If the diuretic is not working, then the only other way to deal with this is try a renal replacement therapy to get the extra fluid off. So this is the algorithm for those patients who come in with a combination of congestion and hypoperfusion. If the same patient has only congestion, there is no hypoperfusion, the only drug which is recommended is a diuretic, because you're only treating pulmonary edema. A diuretic alone is enough. If there is congestion relief, yes, you go on ahead and optimize the therapy. But in spite of being on diuretic, the pulmonary edema exists. There is a recommendation to add a second class of diuretic. So the first class is always a loop diuretic, either a furosemide or a torsemide. And along with that, a thiazide diuretic has been recommended. Now, this is the recommendation from the European Society of Cardiology. If this patient has a diuretic resistance, or the patient is an end-stage renal failure patient who anyway does not make much urine, then you will have to think about renal replacement therapy or dialysis to get the fluid out. Now, this is the algorithm for an acute decompensated heart failure. The next category of presentation of acute heart failure will be those ones with pulmonary edema. Now, in pulmonary edema, most of the times the only problem is pulmonary congestion, hypoxia. And straightforward, it's very easy to say that the answer would be a diuretic. Now, the thing is, a lot of times when you give a diuretic, it takes some time to act. You give a furosemide bolus now, and for you to get a decent urine output, let's say you've got a nasty pulmonary edema, you want at least 1 liter negative. To achieve that 1 liter negative, it may take 5 to 6 hours time, maybe even longer. And this is with a patient who responds very promptly to furosemide. There are many occasions where the patient come in with some sort of a chronic kidney disease. They don't make as much urine as they want to, and you don't get an immediate relief. So that is where the addition of vasodilators, the addition of inotropes, the addition of NIV comes into play, wherein you get an immediate relief from the problems that the patient presents with. So here, patient presents with pulmonary edema. Now, the most important treatment that you want to initiate is oxygen in some form. The oxygen can be started right from nasal prongs to face mask, or you can use a non-invasive ventilation. Or if the patient is extremely sick, ultimately, if nothing helps, after NIV, the escalation is for intubation and ventilation. This is the appropriate oxygen or ventilatory support. Now, the next thing is you need to look at the systolic blood pressure. If the systolic blood pressure is greater than 110, your pressures are decent, then you can think about adding vasodilators. Now, technically, what you want is preload reduction. For the diuretic to give you a preload reduction, it may take a few hours. So if you add a vasodilator like an NTG or sodium nitroprusside, the vasodilation is immediate. It happens within the next few minutes, and the preload reduction is also very prompt, and you can get an immediate relief potentially. That is the reason they're asking you to look at the systolic blood pressure, and if it is more than 110, you have the option of adding a vasodilator. So it's a combination of a diuretic and a vasodilator for those patients with a good blood pressure. Now, if the blood pressure is not good, there are all signs of hypoperfusion. That is hypoperfusion as in poor endocrine perfusion with raised lactates, cold clammy peripheries, poor perfusion to the kidneys leading to oliguria. Here, in addition to the diuretic, they are asking you to add inotrope and vasopressor, which increases the contractility, which causes a vasopressor effect to a certain extent so that the perfusion is streamlined. In this category of patients, it's a combination of diuretic and a vasopressor. But if there is no signs of hypoperfusion and the blood pressure is also not 110, then it's okay. You can just add the loop diuretic alone for these patients, like what you would normally do for pulmonary edema, and wait for the response. If there is a good response, you optimize the medical therapy and continue care. But again, if there is no good response, the final common pathway is pharmacological treatment has not helped. So you go ahead and look for mechanical treatment, like mechanical circulatory support or a renal replacement therapy. Basically, you're introducing machines along with the pharmacological agents. So this is the guideline for treatment of pulmonary edema. Right ventricular failure. Right ventricular failure is quite unique in that it's not very common, number one, and almost always there is a cause, which means that the most important treatment for this problem is treat the cause. So once you treat the cause, which can be a pulmonary embolism, which can be a cor pulmonale, which can be an acute coronary syndrome, like basically an ischemia where you have to revascularize, almost always it improves. But in case this is a chronic right ventricular failure which is not improved, obviously it leads to marked congestion. And the most important treatment for this problem is diuretics. These patients present with lots of peripheral edema, lots of congestion of liver, kidney, gut, and as a result, symptoms relating to that particular organ system. A GI congestion leads to poor oral intake, and as a result, poor bowel habits. A liver congestion leads to congestive hepatomegaly, congestive hepatitis, and long-term cardiac cirrhosis. So the most important treatment for this is loop diuretics. If in case these patients also have signs of poor perfusion, which affects the forward flow as well, automatically we introduce inotropes, and if there is a need, you may also have to introduce vasopressors for these patients. So ultimately, if there is a combination of congestion as well as poor perfusion, that is poor forward flow, you add diuretics for the congestion and you add vasopressors and inotropes to augment the forward flow. If there is relief of symptoms, well and good, you continue management. If there is no relief of symptoms, then the only way to go forward is introduce machines like the other problems. Right ventricular assist device is nothing but RVAD. It's a very novel treatment, which is a temporary treatment, obviously, for a lot of patients until the patient is eligible for a heart transplant. Right ventricular assist device, which helps the right side alone. Or a renal replacement therapy, if we can remove fluid, decrease the preload for the RV, and see if we can optimize. This is for the right ventricular failure. The last category of acute heart failure patients is the cardiogenic shock, wherein this is a dreaded combination where patients present with both wet and cold phenomena. Wet as in they present with edema, either pulmonary edema or peripheral edema, and they are also cold. Perfusion is also compromised. Again, here look for the reasons for a cardiogenic shock. If there is something reversible, like an acute coronary syndrome or some sort of a mechanical complication, then go ahead and treat the cause, because without treating the cause, almost always you're not going to improve. But then if these are patients with no identifiable cause, then you have to go for supportive management. Number one, these patients are wet, so they are hypoxic. So introduce oxygen or ventilatory support, number one. Number two, these are cold patients as well, poor perfusion. So have to introduce inotropes and vasopressors. And on occasions, if they are not amenable to oxygen ventilation, inotrope, vasopressor, you may have to introduce a short-term mechanical cardiovascular support like an intra-aortic balloon pump or sometimes even ECMO. If there is an improvement in perfusion, well and good, you are on the right track. But if there is no improvement, so obviously then you'll have to go to the mechanical side. You will have to think about a long-term mechanical cardiovascular support. So technically here we are talking about either an intra-aortic balloon pump or an ECMO or a VAD, ventricular assist device, depending on the left LVAD or right RVAD if it's a right. And then you may also have to think about the renal replacement therapy, where you can potentially remove fluids, optimize the preload, and see if the heart gets better with that. That's for cardiogenic shock. So I'm going to skip this slide because this is something which we have dealt with. Technically, this deals with the causes of failure. So almost always, as a first step in treatment, they want you to look at the cause of acute heart failure, because that will be the most important step. And without doing that, you're not heading forward at all. So look for acute coronary syndrome, look for an hypertensive emergency, look for arrhythmia, try to do a rate control, rhythm control. It can be as simple as an AF, which once treated, the heart returns back to its normal track. Look for mechanical causes like tamponade or valvular problems. Look for pulmonary embolism. Look for nasty infections which can affect the heart, myocarditis, things like that. Look for tamponade. So technically, you're looking for a cause. That's the most important treatment. And whilst you're treating these patients, some of the non-invasive, semi-invasive, and invasive monitoring modalities, the ones that we regularly use here is PICO, which is pulse invasive contour analysis, continuous cardiac output monitoring. There are many centers which uses your pulmonary Swan-Ganz catheter. That is something which is used predominantly in the cardiac centers. Transesophageal echocardiogram is something which is again semi-invasive. It can be used, but the problem is the probe has to be put inside the esophagus and taken out every time. It can be damaging. Then there is the modern ones, which is more flow track and Vigilio, which gives you a continuous cardiac output measurement. So basically, all these monitoring devices will give you an idea about the cardiac output, will give you an idea about the intravascular volume and the vascular resistance. So at some point, it tells you whether the patient requires fluids or the patient requires an inotropic agent. It tells you, oh, it's not the fluid is okay. It's the heart which is not contracting properly. Then you have to give an inotropic agent. Or is it the peripheral vasodilation? It tells you, no, the fluid is okay, the heart is okay, it is vasodilation, you need to give vasopressors. So a lot of times that is your question. Does this patient need fluids or an inotropic agent or a vasopressor? Most of these devices will give you numbers, which helps you add up the clinical features along with the numbers and get an idea what these patients require. So to put everything into a nutshell, any patient who comes into your intensive care or your operating theater or your emergency department with a heart failure, you look at 3 different phases of treating them. In the immediate phase, try to identify the etiology, look for the cause, treat the cause, and then try to optimize them and optimize the oxygenation, and then optimize the end organ failure. That's the immediate part. The intermediate part, you have to ensure that the cause is treated properly, fully, and then you start titrating the treatment and ensure that these patients move from the acute to the less acute setting, from the intensive care to the ward, with the continuation of care. And last term is the pre-discharge and the long-term care, where you optimize the treatment before discharge in such a way that they go home and have a stable period and prevent readmissions or rehospitalizations. Now, some of the treatment that we commonly use, there is not many treatments available when it comes to acute heart failure. It's diuretics, inotropes, vasopressors, vasodilators, NIV. That's all. There are only 4 pharmacological agents that can be used. Sorry, 3. Inotropes or vasopressors, vasodilators, diuretics. And then other than that, there is NIV. Now, these are the only 4 treatments which can be used for any patient who comes in acute heart failure. You have to identify the category of heart failure and you'll have to balance these things. And if these things do not work, you go to the machines, the mechanical cardiovascular support, renal replacement therapy and all that. Okay. With the diuretics, the recommendation is if they're already on oral diuretic, then you double the dose of the diuretic and give it to them as IV. If they are not on any diuretic when they present to the ER with a wet phenomena, you give somewhere around 40 milligrams of furosemide and see how they affect us. Technically, what you're looking at is a urine output of greater than 100 ml per hour. Then you have a target. How much do you want to get them negative by? Let's say you want them negative by 2 liters in the first 24 hours. Based on that, you titrate your diuretic dose. If you get 100 ml per hour, by the end of 24 hours, you should get 2.4 liters. And then, which means you'll have to look at the amount of fluid you are given, and then are you negative by 2 liters. So based on that, you will have to increase your diuretic dose. A rough idea of how to start is, if they are already on diuretic, double the dose. That's your starting dose. If they are not on diuretic before, you start with 40 milligrams of IV furosemide. This is just one recommendation which comes from the European Society of Cardiology. There are numerous ways of dealing with this. Some people put people on diuretic infusions, furosemide infusions, and it works really well. But all you have to do is monitor them very closely so that you achieve the desired negative balance by the period that you want to achieve. That is with the diuretics. The recommendation is very strong for diuretics, especially the loop diuretics. And if these patients are resistant to loop diuretics, the recommendation is to add a thiazide diuretic and see how the response is. Now, when you add a diuretic, it helps two systems. It improves the pulmonary congestion, alveolar edema, and thereby improves your oxygenation. So it helps the lungs. And in the heart, it decreases the preload. So your left ventricular end diastolic volume and your left ventricular end diastolic pressure is decreased. So the heart is happier, there is lesser ventricular stress, and so the contractility improves. And thereby, finally, the renal function also improves. So your heart is helped, your lung is helped, and finally, the kidney is also helped with the diuretic. The next support, the most important thing is the respiratory support. When it comes to the respiratory support, the recommendation is any patient with a saturation of less than 90% should be introduced on some sort of oxygen support. NIV is a gold standard for these patients who present with dyspnea, tachypnea, and especially when the oxygen is less than, saturation is less than 90%. Of late, HFNC has also been tried. The only difference between NIV and HFNC is that NIV helps with both carbon dioxide component washout as well as oxygenation, whereas HFNC deals exclusively with the oxygenation. It depends on what patient you're dealing with. It's almost always wise to start with NIV, and then once you start seeing signs of improvement, you can work down and start HFNC on these patients. Again, like the diuretic, it has its effect, a good effect on two organ systems. With the lungs, it increases your tidal volume, it improves your pulmonary edema, and thereby improves your oxygenation with the lungs. With the heart, it decreases preload, NIV decreases the afterload, and thereby makes the heart happier and contract better. So that's the non-invasive. The third thing, so diuretic, very useful, non-invasive ventilation or HFNC, very useful. And the third important drug is vasodilators. Now here, in this particular curve, the x-axis deals with the afterload or your systemic vascular resistance. Now this is the stroke volume. So when a normal heart, when the blood pressure increases or your afterload increases, because the heart is normally contracting, the stroke volume does not fall. It just remains the same as a plateau. But then you have a failing heart. Now let's say there is a severe dysfunction. The LV is already struggling to contract and pump the blood out. When the blood pressure increases, obviously it is struggling to pump against a higher blood pressure, a higher afterload, and the stroke volume steadily declines with an increasing afterload or an increasing systemic vascular resistance. Now, this is where your vasodilators come into play. When you decrease your afterload, you make the life easier for your left ventricle, makes the contractility better, and thereby the stroke volume can improve. The commonly used medications are nitroglycerin, sodium nitroprusside, or an acetyl. There is no evidence to say that one is better than the other, and introduce one of these medications only when your systolic blood pressure is greater than 110. The ideal candidate for a vasodilator therapy would be the ones with a wet and warm profile, this category. As we know, the vast majority of these patients are wet and warm category, more than 90%, and ensure that your blood pressure is greater than 110. And then the last group of medications, the inotropes. The inotropes, based on the mechanism of action, we have beta receptor agonist, which is dobutamine. We have digoxin, sodium potassium pump. We have phosphodiesterase inhibitors, which is milrinone and enoximone. And then calcium sensitizer, which is levosimendan. So these are the most commonly used inotropes. Even digoxin is not very common. It's almost gone out of vogue. More of a long-standing chronic heart failure medication than in the acute setup. These three, beta agonist, dobutamine, PD inhibitors, phosphodiesterase inhibitors like milrinone, and calcium sensitizers like levosimendan are the ones which are most commonly used in the acute setting in an intensive care unit for those patients who come in with heart failure. These are the drugs basically. And each and every drug have their own advantage and disadvantage. I'm not going to go into the details of the pharmacology of these drugs. So technically, dobutamine is the most commonly used drug. So anybody who comes into the ER ICU gets started with dobutamine because of its inodilator property. Milrinone has a specific effects on the pulmonary vascular system. In addition to having an inotropic effect, they're also pulmonary vasodilators. So it seems to be a little more preferred for the right-sided heart failure because there is pulmonary vasodilation, and as a result, it improves the function of the right ventricle particularly. Levosimendan is a very good drug. It's got a longer duration of action. So you load your patients with levosimendan. Technically, the effect can last for 1 week to 10 days also. And those patients who are already on beta blockers, dobutamine might not work very well. Levosimendan has a completely different mechanism of action. So these patients, levosimendan is a preferred drug. A lot of our cardiac patients, when they come in with failure, they're already on beta blockers. So at this point, levosimendan might be a good choice. So they have their own advantages and disadvantages. So inotropic agents, yes, they are very good drugs, but then there is a very specific indication. Gone are those days where any patient who comes in with heart failure gets started on an inotropic agent, like a dobutamine. Put them on dobutamine, put them on dopamine. Those days are gone. There are specific reasons why you want to put these patients on inotropes, because very much like their good effects, there are a lot of bad effects from inotropes also. So the recommendation is that you put them on inotropes only when the systolic blood pressure is less than 90 and when there is evidence of hypoperfusion, which does not improve with your standard treatment, including fluid challenge. So not all patients. You should have a few boxes ticked. The systolic blood pressure should be less than 90. And after your standard treatment of fluid and all that, there should be signs of hypoperfusion. What are the signs of hypoperfusion? Cold, clammy peripheries, capillary refill time greater than 3 seconds, lactate greater than 2, signs of end organ problems like acute kidney problem, oliguria, signs of liver problems. So these are end organ perfusion signs. And only if you have any of these signs along with a low systolic blood pressure of less than 90, you start them on inotropes, because inotropes increase your heart rate. They are bad drugs. They can cause arrhythmias. They obviously increase your myocardial oxygen demand. Your heart is already struggling without enough oxygen. By flogging the heart further with inotropes, you may cause more damage. They can also have a direct toxic effect on the heart. And there are many studies which has been done on the effect of inotropes, and the routine use of these patients have found to be detrimental. So no routine use of inotropic drugs for heart failure patients. There are specific indications. Systolic BP less than 90 for organ perfusion. These are the only 2 times. Okay. So these are the patients, those patients who come out wet and cold with these boxes ticked that I mentioned already. You use it for the shortest term possible. Use the lowest dose possible. And there is no evidence to say that one agent is better than the other agent. Whichever you are comfortable with, either dobutamine or milrinone or levosimendan, you can use it. That's not a problem. Moving to device therapy, when would you use a renal replacement therapy? The indications are standard. There is no routine use of ultrafiltration. The standard reasons is to decrease the fluid overload when there is a diuretic resistance, when there is a severe hyperkalemia, severe metabolic acidosis because of the renal failure, urea, uremic encephalopathy, uremic acidosis, and a creatinine value. Usually creatinine value is not a great indicator, but the other ones, especially fluid, hyperkalemia, acidosis, and urea, these are indications for renal replacement therapy. And these are standard indications anyway, even without an acute heart failure problem. When it comes to the other mechanical assist devices, IABP is something which is relatively commonly used in a lot of cardiac centers with patients present with acute coronary syndrome, like a heart attack, MI, along with a cardiogenic shock. But that said, in cardiogenic shock, it's got a decent evidence. But beyond that, IAPP does not seem to improve outcomes in some of the trials. So it is still a big question. But it is one of the useful tools. And then left ventricular assist devices, mostly as temporary devices or a bridge to transplant. Whereas these patients have a permanent heart failure, end-stage heart failure, they have to be transplanted, and during the waiting time, they can have a left ventricular or a right ventricular assist devices. My slide is not moving.
Yes, it's not moving.
Yeah. Not able to control it. Almost done with the presentation here anyway.
Rajesh, sir?
Yes, sir. Yes, sir. It's now
yeah, moved too fast now. Anyway, so technically, there are scoring systems to understand the in-hospital and out-of-hospital mortality for these patients. So acute heart failure patients can be scored with this IDEA score or Elan HF score. These are two popularly used scores to understand how these patients are going to fare with your treatment. And to put everything in a nutshell, to consolidate, the most important treatment for these patients is treat the cause. Why do they come in with a heart failure? Go after the cause first. And once you address the cause, then the next important thing is relieve the symptoms of congestion and the low output state. Once you relieve the congestion and low output state, and then how to have these patients in a stable condition, and these drugs should be introduced to stabilize them before discharge. So this is the most important step which prevents readmission of these patients to the hospital. Educating the patient and the family is a very important step, and that's all my talk is about. And almost all the information and evidences that I've put in this slide has been borrowed from the European Society of Cardiology and the American Heart Association. Thank you.
Thank you, sir. Rajesh, sir.
Yes, sir. Thank you, sir. Thank you, sir. It's excellent talk. And so a lot of information, and we have some queries to take up. Shall I start with the questions, sir?
Please, sir.
Sir, this forum has a lot of MDPGs. So the questions are related to that role of dopamine versus dobutamine in cold and
dopamine. The problem with dopamine is that dopamine is a very commonly used drug in our part of the world, but because of its side effect profile, especially in the form of tachycardias and arrhythmias, in the adult population, it seems to have gone out of work, sir. In the adult population, the biggest strength of dopamine, the reason we are still talking about it, is that it does not cause a vasodilation. That's the advantage of dopamine. Whereas the other available inotropes like dobutamine, melrinone, levosimendan, all these, in addition to having an inotropic effect, they are also dilators. So a patient who's got a borderline blood pressure, when you introduce dobutamine or melrinone, I expect a blood pressure drop. So a lot of times I end up adding a vasopressor, a noradrenaline along with that. Now I'm on 2 drugs now. Whereas if I add dopamine, at least I don't have the dilator problem. But that said, dopamine carries lots of arrhythmias. So as a result, people are shying away from using dopamine in the adult population. It is still a very popular drug as an inotropic agent in the pediatric age group, but not on the adult side, sir. There has been a few studies which looked into the dopamine and the outcome and all that, and there is not a favorable profile for dopamine, and people are shying away from using it.
Sir, opinion on ionodilators like milrinone and levosimendan instead of NTG and SN.
The most important question, again, as we saw in the algorithms, is that do you have both a pulmonary congestion as well as a perfusion problem, sir? That is the most important question. When there is pulmonary congestion alone, pulmonary edema alone, the choice would be a combination of diuretic and a pure vasodilator, like an NTG. So, if there is a combination of pulmonary edema as well as a perfusion problem, that is when you want to add an ionodilator. Now, the reason I don't want to add an ionodilator for the first category is, as I said, all these inotropes have a very bad profile with the heart. They increase the heart rate, they cause arrhythmias, they increase the myocardial oxygen demand. Dobutamine, milrinone, levosimendan, enoximone, all these drugs have a very bad profile when it comes to causing heart rate worsening, arrhythmias. And so I don't want to give these drugs who do not have a perfusion problem. If they have a perfusion problem, yes, definitely I will give it. So which means that for pulmonary edema alone, I will only use a vasodilator and a diuretic. But if there is pulmonary edema and poor perfusion, I will add diuretic plus an ionodilator.
So how early we can go for MCS, mechanical cardiac spasm?
How? Sorry,
how early we can go for in heart failure?
It's mostly for treatment resistance, sir. It's mostly for treatment resistance. So it depends on how soon you're able to ascertain that your routine pharmacological and your other mechanical supports like renal replacement therapy and IABP have failed. There are occasions where we take care of patients in the cath lab. These patients come in with a severe acute coronary syndrome and a severe cardiogenic shock. Whilst we are doing catheterization, whilst we are trying to revascularize them, they can arrest. And whilst we do see insert an IABP, sometimes we insert an ECMO also. There, how soon as a few minutes to 1 or 2 hours, we introduce ECMO. But then there are patients who are not that sick, who don't crash, but who do not improve over a period of 1 or 2 days. Then we understand that we have exhausted all the standard measures. The patient is not improving. There, it's over a period of 1 or 2 hours, we realize that this patient is not amenable to standard treatment. There we go on ECMO. So it all depends on how soon you're able to ascertain. If I have a patient who's crashing on the table in the cath lab, within the next half an hour, we will introduce even ECMO.
Sir, role of digoxin and morphine in heart failure?
Morphine is definitely a drug which is, I would call it as a rescue drug, especially being a combination of an anesthetist and intensivist. I love administering morphine for my patients for 2 reasons. When they come in with acute coronary syndrome and a lot of pain, I see that morphine works better than fentanyl a lot of occasions when it comes to pain alleviation. And then when it comes to stabilization of my sympathetic nervous system, definitely morphine is much better than fentanyl. This is my personal opinion, though. I can't quote any studies over here. And it definitely breaks down my sympathetic response, and it's got a very favorable profile with the heart. So morphine is a wonder drug, I'm sure. Then you have to ensure that it doesn't compromise your respiratory system, because a lot of times these patients come with pulmonary edema as well. You have to be very cautious in administering. And digoxin, yes, my most common use for digoxin these days is for rate control and atrial fibrillation than for cardiac failure itself. There are patients who are resistant to routine management of atrial fibrillation. We put them on beta blockers, optimize their electrolytes, we start them on amiodarone, doesn't work. Then we take up digoxin as a rescue drug more for rate control. Even with the cardiologist fraternity too, that seems to be a much more common indication for digoxin than as a drug for long-term cardiac failure treatment. Unfortunately, at this point of time, all the available evidence for digoxin says that it doesn't improve mortality, but it can improve quality of life. So still is being used by the cardiologist as outpatient therapy. And we don't do digoxin levels regularly. That's another problem.
Sir, some questions related to anesthesia. So in pre-anesthetic evaluation, is there any criteria for echo criteria to get the patient fit for elective surgeries?
For NICO.
Echo. Is there any criteria in the echocardiogram findings to get the patient fit for elective surgery?
Fitness for, I think I didn't understand the question. Can you rephrase it?
No, it has been asked like in PAE, is there any criteria for the echocardiogram to be done during pre-anesthetic evaluation that to get the patient to be fit for elective surgery? That's a question from Dr. Prema.
Okay. If I take this question as who are the patients who should require an echocardiogram in the pre-op assessment period, then my thing is that there are really in the current condition, there is no specific criteria. If my patient goes in for a major surgery, which would probably warrant a post-operative intensive care, which is a surgery which can particularly jeopardize the cardiovascular system. A lot of times we have young patients who go in for HIPEC surgeries, and in the perioperative period, because of the therapeutic agents, because of the fluid shift, we expect a lot of cardiovascular changes in the perioperative period. So I would like to have a baseline. So even in the younger age group, if it's a major surgery, I ask for echocardiogram. And then in the relatively older age group, we have a very low threshold to ask for an echocardiogram if there are slightest of the symptoms. Unfortunately, a lot of our patient population don't go in for a regular evaluation. So a lot of times, when during the pre-op assessment, there is incidental findings, wherein you do an echocardiogram as a routine thing, you identify there are major problems. So my practice over the last few years after coming back to India has changed dramatically, where I think I'm probably asking for ECMO on almost 60 to 70% of the patients beyond the age of 60 years. I guess it's just we have to be very sensitive to the clinical examination and have a low threshold to ask for echo.
Thank you, sir. Thank you very much. There are some more questions in chat box. Because of the time lag, I'll message you the questions and I'll get the answer from you in the chat box.
Pleasure. Sorry.
Thank you, Sabha, sir, for your spending your valuable time with us. Thank you. Thank you.
Thank you. Pleasure.
So we will move on to the next session, session number 2, by the how do I safely ventilate my patient in OT? By Professor Dr. P.R. Chandrashekar, sir, who is the head, Department of Critical Care Medicine, IGOT, Bangalore, Karnataka. We welcome you, sir, and for the lecture. Over to you, sir. Professor Chandrashekar, sir.
Yes, sir. I'm trying to share my slides. Just give me a second. Are my slides visible, sir?
No, sir. Yes, sir. Yes, sir. So visible.
Yes, sir. Visible, sir.
Okay.
You can see it.
I would, at the onset, I would like to thank Dr. Johnson and the anesthesia colleagues for inviting me to do this lecture. Mostly I do, as my previous speaker, work mostly in the intensive care, but my basic specialty is anesthesiology. So I did take up this talk, how do I safely ventilate my patient in OT? If you look at the literature from the Las Vegas study, which was published in 2017, it's a huge study with nearly 10,000 patients, 38 countries, 146 centers, mostly in US and Europe. India was not included. What they found was tidal volumes were reasonably okay. The amount of PEEP that most of the anesthesiologists are using is very less. About 32% is using less than 2 centimeters, and about 60% of them are using about 2 to 5 centimeters of water. And about less than 10% are using recruitment maneuvers. So there is a good focus on low tidal volume ventilation, but the amount of PEEP used is very low, and there is no recruitment maneuvers. See, these are the few best centers in the world. I'm sure, very much sure that if you do a similar kind of survey in India, probably tidal volume also usage is much higher, because I do interact with a lot of anesthesiologists, and for them about 9-10 ml is the normal. So having looked at the way the world is ventilating, there is a lot of scope for us to learn how to ventilate our patients safely. So the next obvious question is, why do ventilate our patients undergoing surgery? Most of the times it could be a patient's choice, or the surgery warrants GA. And another common misconception that every anesthesiologist carries is that my lungs are normal, so whatever, for a short duration of 1 to 2 hours, if I ventilate with higher tidal volumes or less PEEP. And another common thing that I hear from anesthesiologists is that PEEP reduces blood pressure. That is something every anesthesiologist, there is a strong kind of a rooted belief that PEEP causes hypotension. This is what most of them have a belief or a myth. So thinking that you have a normal lung and trying to induce or ventilate the way with higher tidal volumes, low PEEP, doesn't do much good to the patient, because most of the studies are showing that the post-operative pulmonary complications in different studies go up from 7% to 40-50%, and in some high centers operating major cases like in cardiothoracic centers and in our center, I'll show you a statistic that we have found out. We have very, very high incidence of post-operative pulmonary complications. What constitutes post-operative pulmonary complications would be most commonly, though there are some additions, I would say what we see is respiratory insufficiency, failure, atelectasis, pneumonia, and bronchospasm. These are mostly what we see, sometimes pleural effusions and rare complications we do see, but these are the 4 which we commonly see. And when somebody has this PPCs, there is an increased morbidity, the length of the stay increases, the economic burden increases, and the mortality increases. Added to this, in the post-operative period, there is always a pain component that also we have to factor in, which also again contributes to patient not taking very deep breaths, not cooperating with physiotherapy, incentive spirometry, good cough maneuver. So this also in the post-operative goes to the post-operative period. The way we ventilate the patients intraoperatively is what accounts to how well the patient behaves post-operatively. This is what we have to understand. It is not enough that we ventilate somebody with good saturation, a decent amount of EtCO2 and send them out of the theater and think my job is done. It doesn't, because most of the anesthesiologists in most of the medical colleges and centers now are managing the intensive care units also. So the impetus should be on ventilating with a lung protective ventilation, which I'll be discussing, because we want to minimize or in fact avoid post-pulmonary complications. So the question is, do all our patients have normal lungs? Look at here, a 40-year-old guy with 4-day-old perforation, peritonitis, already requiring 50 liters of oxygen on a non-rebreathing mask. His saturations are 95. He's getting almost like 100% of FiO2. And his SpO2, if you look at the SpO2 FiO2 ratio, it almost lands up into a severe ARDS. His respiratory rates are high. Then he's restless, posted for emergency laparotomy, urine output is adequate. So do you think that ventilating this guy with a high tidal volume, low PEEP would do? Because he already has a tendency to go to ARDS because there is a gram-negative sepsis. And if you ventilate you don't ventilate this patient with a lung protective ventilation, that becomes a second hit to the lung. And the patients tend to develop ARDS, probably partly because of the disease and partly because we have not done the ventilation with a lung protective framework. See, this is something you have to keep. Don't think that every lung that you get is normal. Look at this patient. We have a normal young lady, pregnancy, then she goes into PPH, not responding to drugs. We have 1 unit of blood, we transfuse. We are organizing blood, then push in a lot of fluids, then we get it goes into a massive transfusion protocol. See, a normal lung can become abnormal on the theater. So the bottom line, what I want to underscore is three things. One, every patient, even with a normal lung, is known to get into a PPC. So it is better to institute a lung protective ventilation. Sometimes you may get bad lungs or a grade 1 or a mild ARDS on your table. And the third one is, we don't know. Any patient can go into a situation where the lung from being good can become a lung which is prone for ARDS in the postoperative period. So my one take-home point is, don't think the patient's lung is normal. Even the lung which is normal can produce a post-pulmonary complication. So that is what I want the younger colleagues of mine to understand, that every patient who gets onto your table under general anesthesia and mechanical ventilation has to be instituted a lung protective ventilation. In our unit, because we operate complex GS surgeries, when we do ultrasound on the first postoperative day or immediately postoperative day, almost I would say every patient has a basal collapse and some B lines. The upper portions will show A lines, but most of our patients show basal, and the pulse point generally show B lines with a lot of collapse. So this is not something that is what you have to think is, because we have been seeing from so many years that every patient has atelectasis. Though we do have lung protective ventilation in our unit, we have implemented it, but still we get into a lot of patients with atelectasis. So it's a problem that we have to accept. It is there. It is there. So most of my material that or the information I'm going to give is based on this article. This is one article published. These are most of the guys involved are from the Las Vegas study group from US and Europe. And it's a good paper. I recommend all the postgraduates to have this paper in your desktops or laptops and keep it as a reference for you to keep updating the practice, anesthesia practice and mechanical ventilation. So the obvious question is, as I said, in our unit, as patients are elderly and most of them have atelectasis, is there a way to assess which patients are more prone for having post PPCs? So there are a lot of scores like the Ariscat scan score, Gupta score, and Arizula score. But my personal experience with scoring systems there are too many scoring systems. So generally, we don't tend to really sit and spend so much time assessing the patient. This is what happens. So probably the consensus group also felt so. So they have come up with very, very precise and very easy to see where it is so obvious that these patients are more prone for PPCs. This is very obvious. Anybody having a BMI of more than 40, age of more than 50 years, physical status of ASA more than 2, sleep apnea, and COPD patients also, preoperative anemia, preoperative hypoxemia. As I said, COPD would qualify probably with hypoxia and hypercarbia both, emergency and urgent surgeries, because probably most of the times, like they will have some trauma or they will have some hit to the lung already. That's why emergency and urgent surgeries these patients are more prone for PPCs. Ventilation duration more than 2 hours, and intraoperatively anybody has hypotension, low SpO2s, probably these are the patients who have increased incidence of your post-pulmonary complications. It's very simple and you can remember this. This is not very difficult for postgraduates to remember, and it is always better to optimize them preoperatively. There are some modifiable risk factors, some things you can't modify like age, you can't modify somebody's weight. Probably you can ask them to go back, lose weight and come. Sometimes in emergency situation, it may not be possible. In pregnancy with morbid obesity, we have to go ahead with surgery, and cessation of alcohol, smoking, any treatment of infections, especially in COPD patients, and relieving of bronchospasm, and Also anemia, but probably how it decreases PPCs, probably if somebody has anemia, we may have to use a higher FiO2s, things like that. So that also can be taken into account. Educating regarding physiotherapy probably is important, because the patients in the post-operative phase, when we have counseled them and when they already know how to do incentive spirometry, they are more motivated. You can talk to them, you can educate them. We have seen this. The patients are more cooperative to do chest physiotherapy and also incentive spirometry. So in the next few slides, I'm going to look at the respiratory physiology and mechanics for you to understand what happens in GA and why you should go for a lung protective ventilation. I've always learned that if a postgraduate learns the logic behind what we tell, why it has to be done, he does it better. If you just say, if I can just say in a slide that the tidal volumes have to be between 6 to 7, everybody has to have a PEEP of 5 centimeters, and you can do recruitment maneuvers and end my talk, it's not going to be of great help. I want them to understand what happens at the alveolar level and how to identify who requires adequate, who requires PEEP, and how to personalize somebody's PEEP, and which patients require recruitment maneuvers, so that you will have a, because we do see a lot of different type of category of patients with different category of surgeries. So the combination of an acute stress imposed on a patient with a decreased physiological reserve becomes sometimes tricky to manage the patients intraoperatively and postoperatively. So understanding what really happens at the alveolar level is going to give you more confidence or more grip over the management of tidal volume, PEEP, and recruitment maneuvers. See, this is what you have to understand. Lung doesn't expand by itself. Normally we suck air in, but in a ventilator, we are going to push air in. And lung and chest wall are in a series. This is very, very important. You remember this. I will tell you, at times when somebody has a high peak pressure and high plateau pressures, it is very, very easy to differentiate whether the contribution is from the airway or the lung. But sometimes it becomes very difficult to differentiate whether it is contributed by the chest wall or the lung. But one caveat I want to put it here is, any chest wall difficulties are obvious, like somebody has a pneumoperitoneum, somebody has a huge hernia being pushed in and stitched, or reverse Trendelenburg position. So you know that there is a chest wall component that is hampering your diaphragmatic movement, or the respiratory pump is being hampered. Then if your peak pressures and plateau pressures go up, probably you will not worry much, because the alveolar pressures are not high in these situations. But clinically, exactly to point what contribution of the peak, plateau, or your driving pressure is because of the alveoli or the chest wall is at times very difficult to make at the bedside. We'll see how well we can do it for a course of time clinically in the next few slides. And lung also has more alveoli here and more blood supply, less alveoli, less blood supply. So we have a PQ mismatch. On a supine position, because of the superimposing, it's like keeping a wet sponge. When you keep a wet sponge, the weight of the over on this part of the lung is going to put pressure here. This we call it a superimposed pressure. This is more common in a sick lung because of alveolar edema. The lung weight is more, so the bases collapse. And that is the tendency for us to see in the pulse point or in the bases, a lot of collapse. It's physiologically like that. In a supine position, under general anesthesia, there is more collapse and atelectasis at the base. That you have to understand. And another thing, what I want, this slide has been put up for you to understand that the tidal volume goes in and comes out on a volume that already exists in the lung. So that is called FRC. The tidal ventilation occurs over FRC. So increasing the FRC by introducing PEEP is going to increase the surface area of the alveoli, which is in contact with the blood vessels. So the oxygenation occurs better. And another advantage of increasing the FRC is you have more alveoli to accept the same amount of tidal volume. So the pressures that you achieve are not very high. So you have to, when we speak of tidal volume, don't always focus on tidal volume. Tidal ventilation occurs on FRC, the functional residual capacity. That's what I want you to remember. See, this is what I was saying. The transpulmonary pressure is what is the main determinant of VILI, the ventilator-induced lung injury, and ventilator-induced lung injury, the transpulmonary pressure. See, there are two instances. One patient, both patients have a transpulmonary pressure of 30. Look here, this chest wall is very, very rigid. Chest wall is contributing 20 and alveoli is contributing 10. Whereas you look here, it's ARDS lung, it is contributing 25 and a chest wall is only contributing 5 centimeters for this pressure. This may happen even with the pressures we measure, a plateau pressure, a driving pressure, which I'll come. Don't worry, I'll explain it to you what it actually means, how to ascertain on the operating table and how to manipulate your ventilatory settings and parameters so that we know what are the lung protective ventilation boundaries for us to operate. What is the boundary with which we have to manipulate our ventilatory settings is what is the crux of the talk. So what I want you to understand is, if you see a plateau pressure or a PIP pressure of 30, it doesn't mean anything. The contribution, we don't know what is lung is contributing, how much is the chest contributing. For this, you have to put in a esophageal balloon so that you measure the pleural pressure, and once you measure the pleural pressure, then you can separate the difference of what the chest wall is contributing, how much is the alveoli contributing. But the whole situation in an operating theater, in most of the ICUs also, we don't do this. So ascertaining the contribution of the chest is always clinically. We look at any rise in the intra-abdominal hypertension, any position changes, any pneumoperitoneum, obesity, any grass, edemas. This is what the chest wall contribution is, how you ascertain. It is not possible to ascertain what is the contribution of the alveoli or the chest wall in the operating room. But it is quite obvious. Many times it is quite obvious that when we intubate somebody, look at your PIP pressures and plateau pressures, then once in a laparoscopic patient, once the pneumoperitoneum occurs, if the pressures go up, probably you should not get worried. You should not get worried. You know, because the diaphragm is not going up, the chest wall or the respiratory pump is contributing to the increase in the pressures. In such situations, you can be more bold, put up more PEEP. You can do a recruitment maneuver. But if you have a patient on supine, at the beginning of the surgery, his PIP pressure is only 15. Suddenly, he develops pulmonary edema. There is a pink frothy sputum coming out of the endotracheal tube. Then you know it, the contribution is from the alveoli, not from the, or the patient has aspirated. Then you know the chest wall has not contributed, it's more. Then you have to be very careful. Those are the patients who go for ARDS, and it's very difficult to manage in the post-operative situation. As I said, the transpulmonary pressure, to do this, you require esophageal balloon. We generally don't do. We don't do the FRC estimation also. Some ventilators do give FRC, but most of the anesthesia ventilators may not have it. So we generally know only the tidal volume. So we use surrogates here. What are the surrogates we use to look at the pressures? We use the PIP pressure. We look at the plateau pressure. We look at the driving pressure, and we look at the positive end expiratory pressures. These are the 4 pressures you should know. Without knowing these 4 pressures, you are not doing a justice to your patient. And it is not accepted in a present day anesthesia practice that if you don't note down the PIP and plateau and the driving pressure at the onset of anesthesia, you are not doing a good job. This is the standard of care in all the centers in the world. I will explain it, how to get there and what it all means to. So what, from this slide, I want the postgraduates to understand 2 things. The best pressure to look at is transpulmonary pressure, which you require to float a esophageal balloon. There are a lot of technical issues. In most of the Indian ICUs also, we are not doing. So we use these surrogates. The surrogate pressures are the PIP pressure, the plateau pressure, driving pressure. These are the 3 pressures that you have to know whether we are within the boundary of lung protective ventilation. You should always remember that oxygen delivery is not oxygen transfer to the blood, to the pulmonary blood is not the goal. For every anesthetist should remember this. You should always think that oxygen delivery to the mitochondria is the goal. And it's a cardiorespiratory function. Because we always focus on the macro circulation. We are fixed to macro circulation. So this is something that you have to always consider, whether my delivery and my requirement, is it sufficed? How to look at this? If the patient is not anesthetized, mentation, urine output, a capillary refilling time. It is very easy. At the bedside you can do. Then if you have the ABG, then you can look at the lactate and SCVO2. This is what tells you whether your oxygen delivery for mitochondria is adequate or not. If whether your oxygen delivery is adequate to mitochondria. And it's a cardiorespiratory function. And it's a thoracic cage is a fixed structure. And any increase in the intrathoracic pressure always compresses your heart, decreases your preload, cardiac compression, decreased preload. Though it increases, it decreases the afterload, but the preload decrease is much more when somebody is fluid deficit. What I want you to understand is whatever parameter you change on the ventilator, always think that it might affect your heart. And if your blood pressure falls, you may have a PaO2 of 700, 500, but it's not going to reach your mitochondria because the perfusion pressures are not there. So oxygen delivery to mitochondria is a cardiorespiratory function. Always remember that. And whatever you change on a ventilator, always look at your hemodynamics. And if possible, in a long surgery, you can always look at the lactates, SCO2, urine output, and your PCO2 gaps. Those are easy to understand. They do give information that something is happening at the cellular level or the microcirculatory level. One thing you have to understand the pressures, as I said, the surrogates of your FRC and the transpulmonary pressures, I said we have to look at three pressures. One is peak inspiratory pressure, the second one is plateau pressure, and the third one is driving pressure. To understand that, you should know that alveoli is a cul-de-sac, meaning that there is only one way the air gets in and gets out. So when you put air into a closed space or a tidal volume into a closed space, what increases? Can any postgraduate type in the chat box? What increases when you put volume in a closed space? Because I have about 3-4 case scenarios, we'll have 1 or 2 volunteer postgraduates and discuss how to set the ventilator. So what increases if a volume is placed in a closed space? That's 3-4 messages. Okay, fine. That pressure increases, isn't it? Pressure increases. Obviously, pressure increases. My slides got stuck. And in which alveoli do you think pressure increases more? In A or B? In A or B? Which pressure, it increases more? Can anybody type? Which alveoli? In A alveoli or B alveoli? B, yes, obviously, isn't it? And air always chooses the path of least resistance. Remember this, it's very important. It's a very important concept that you have to, the lung, even a normal lung in a supine position under general anesthesia is heterogeneous. Not all alveoli has a time constants. There are basal collapse and the lung, the air always goes preferentially to more compliant lungs. So you have to understand that. And because that something happened. Yes. So pressure increases. Okay, volume change for a change in pressure is compliance. For all practical purposes, whenever you put a volume, think that if your pressure goes up, that the lung is stiff. We can use complicated words, and I can make it more complicated, saying that compliance, inverse of compliance is less than. For you and me, when a volume gets into the lung, I see a higher pressure. My assessment is there is a problem with either the airway or my lung is stiffer, or my chest wall is contributing to increase in pressure. I will show you and I will explain it to you how to differentiate whether the contribution is from the airway or the lung. And as I've said, between the lung and the chest wall, the only way is to float a esophageal balloon, which we are not. And most of the times under anesthesia, it is very easy to ascertain whether the chest wall is contributing or the pump is getting restricted for movement. That is what the chest wall contribution actually means. So we have to monitor pressures. You understand why we are looking at pressures? Because when volume goes into a cul-de-sac, it produces pressures. And there are three pressures which gives us the boundaries of lung protective ventilation. One is, can somebody type all the three pressures, please? See, somebody is asking me if pneumoperitoneum is there, how to maintain a driving pressure of less than 13. I don't want to maintain a driving pressure of 13, less than 13. That's what I mean to make you understand, because the contribution is not from the alveoli. The pressure is being delivered by the ventilator to push your diaphragm down. So you don't injure your lung at that situation. So when somebody has hemoperitoneum, pressure goes up, you know you are pushing the pressure or you increase the pressure from the ventilator to increase or expand your respiratory pump. That's what is the meaning. What are the three pressures that we spoke of? Yes, somebody has typed. That is good. Oh, sorry. Okay. So those are the three pressures. I'll in the next few slides, I will look into what contributes. Oh, whenever the chat comes, I'm getting it more difficult to start my slides again. Okay. So this is one important slide that every postgraduate has to understand. See, we do a lot of settings. We say 6 ml. So then we set a PEEP, then we set a respiratory rate. This is under our control. This is a volume or an intensive property. What does it go and meet? It goes and meets, and we look at the plateau pressures, driving pressures. As I said, PIP comes without doing anything. So three pressures will be ascertained. Whenever you start anesthesia, you do an inspiratory hold of 2 to 3 seconds. It works very good with volume control ventilation. And most of us do use volume control. You can use pressure control also. There is no great difference between the two. But you should know how to evaluate the plateau pressures and driving pressures in a pressure control ventilation. But in a volume control with a constant flow, if you put an inspiratory hold, there will be a button. I'll show you on the ventilator. Just hold it for 2 to 3 seconds. Then probably you'll get a plateau and driving pressure. Then it goes and meets the alveoli. This is the capacitance property. See, the alveoli may be totally collapsed, maybe normal. Then we get the transpulmonary pressure, which we don't ascertain. Then we look at the surrogates. These are the surrogates: PIP pressure, plateau pressure, and driving pressure. You can remember the values. In anesthesia, we want to maintain the plateau pressures less than 16 to 17 centimeters of water, driving pressure less than 13 centimeters. Driving pressure, I'll tell you what it is in the next 1 or 2 slides. These are the surrogates. This is what we said when it goes and interacts with the capacitance property of the lung. Meaning, if somebody has an alveoli, all alveoli are open. So the tidal volume goes to more alveoli. So your pressures will be less. In this lung, the number of alveoli that are open are very less. And we did understand that air always chooses the path of least resistance. So the normal alveoli or your baby lung gets over distended. So the pressure goes up. This is what I want you to conceptualize when you look at the pressures on the operating table. When you intubate somebody, put him on a volume control, set all the settings. First thing you should see is the PIP, peak inspiratory pressure. If the peak inspiratory pressure itself is less than 15, 16, probably you know the lung is good. And if it is less or more, then do an inspiratory hold, you get a plateau pressure. And you minus from plateau pressure, the PEEP, you get the driving pressure. The values I've said is less than 16, less than 13. So this is what and how you start mechanical ventilation to every patient. This is because studies have shown us the boundaries of lung protective ventilation. We want to keep the lung within that boundaries so that we don't produce post-pulmonary complications. See, if somebody is blowing to this, will the pressure increase more or to this? Obviously, when the number of alveoli which are capable of receiving your tidal volume is less, the pressure goes up. That is what I want you to conceptualize. Whenever the pressure goes up, you should think, is it contributed by my airway, my lung, my chest wall? As I've said, chest wall is easy because it doesn't acutely change. And we know whenever it changes, probably something has happened because of the position, pneumoperitoneum, a hernia surgery. Sometimes the surgeons may open up the abdomen like in liver transplant and put 30-40 mops. And there will be 10 retractors being pulled. So the diaphragm doesn't have space. When the pressure goes up, I know that it is being contributed by my diaphragm not being pushed. I don't mind increasing my plateau pressure to even 20, 25 in that situation, my driving pressure to 20, because I know lung is not getting hit. That is what I want you to understand. So these are the pressures, and this is and P-plat is a surrogate of your end inspiratory alveolar pressure. It's a surrogate for your end inspiratory alveolar pressure. Remember that. See, this is the most important button on your ventilator. You should know this. There will be all of your anesthesia modern day ventilators has an inspiratory hold button. Whenever you intubate somebody, first look at your PIP pressures, then do an inspiratory hold of 2 to 3 seconds in a volume controlled, and most of our patients will be paralyzed. In anesthesia, most of our patients will be paralyzed, though there is no question of difficulty that we face in the critical care units, where we don't want to keep them paralyzed for a long. For you, most of your patients are paralyzed, so it's very easy to do an inspiratory hold. And what do you get? You get plateau pressure, driving pressure. Driving pressure is nothing but plateau pressure minus PEEP, and compliance is tidal volume divided by driving pressure. These are the 3 parameters you tend to look at. The PIP will always be there. Whenever you see on the ventilator, PIP will be there. So then you evaluate the plateau and the driving pressure, then look at the compliance. So what does it each mean? What does each mean? This is one important slide. I want all of you to concentrate and remember that all your life to give a lung protective ventilation. First you get PIP. To get plateau pressure, what is the maneuver we do? Can anybody type in the chat box? What maneuver should you do to get a... Can anybody type what is the maneuver that we do from plateau pressure, from PIP to get a plateau pressure? It has to be in a volume controlled mode. Patient has to be paralyzed. And the maneuver that we do is what? Yeah, inspiratory hold. Somebody has typed. I'm happy that you understand that. So then you get a plateau pressure. What does plateau pressure signify? It's a surrogate of end inspiratory alveolar pressure. See, this will include both the PIP will include both the resistance component and the alveolar component or the compliance component. So once you shift from PIP to plateau, the contribution is all by the alveoli. And the difference between PIP and plateau is called the trans-airway pressure. See, when you intubate an asthmatic, suddenly the peak pressure goes to 45. And if you do a plateau pressure will be 20. So the trans-airway pressure will be 25. Then you know the contribution is because of the airway. And the difference between the plateau and PEEP is the driving pressure. I'll tell you what it is. See, remember this. Remember this slide forever. This is contributed by the airway and this is contributed by the alveoli. From coming from here to here, you have to put an inspiratory hold. And the difference between these two is the contribution of the airway. Whenever you see a high PIP and a low plateau, it is always because of the airway. You need not worry. I would go up and increase my peak pressures to 60 and ventilate my patient. I am very much sure nothing will happen to my alveoli because all the energy is dissipated by stretching or going through your narrowed airway. The pressure goes there only, it doesn't hit your alveoli. So that is very easy. Once you do, see, whenever you suddenly see a patient difficult to ventilate, just put a plateau pressure. If the plateau pressure is low, you can be very comfortable. You can nebulize the patient, you can deepen your anesthesia, you can give ketamine, you can give magnesium, you can give your aminophylline, you can nebulize, because you know that it is because of the airway. You don't require to auscultate also. But I don't mean to say that you shouldn't auscultate, but you can find what is the contribution. See, what are the difference between the two pressures is the PIP will include both the airway and the alveoli. Plateau will include only the alveolar pressure, and driving pressure is the pressure that you require to put the tidal volume. You require to put the tidal volume. That is what, see, your plateau includes peak. There is a static pressure also included in your plateau. Whereas in your driving pressure, it is between the peak and the plateau. So this is the pressure required to put the tidal volume. So that is what tells you whether your tidal volume is adequate or not. See, when you put a tidal volume, then suddenly you see the driving pressure going up. Obviously, when the driving pressure goes up, the plateau also goes up. No doubt about it. But that is the pressure you require to put the tidal volume into your lung. That is what you have to remember. Which is the resistance issue and which is the compliance issue. See, this is the PIP. This is the plateau. The trans airway pressure is bigger here or bigger here. This is the compliance issue. This is the resistance issue. It's very easy to make out. Both the P-plat and your driving pressure will be raised. Here, P-plat and driving pressure will be normal. Or sometimes driving pressure may be more also. What you have to understand is that by looking at the small maneuver, you can differentiate whether the contribution is from the airway or the alveoli. So, to summarize, I will ask you a few questions. How do you estimate P-plat? What are the prerequisites that it should be there? Can somebody type it? In which mode do you do? Whether the patient can be spontaneously breathing or not, and what is the maneuver you should do, and for how much time. See, if you hold the inspiratory hold for more than 5-6 seconds, you get a lesser value. Should not do. It should be always for 2 to 3 seconds, not more than that. Yes. So all the questions have been answered. So I will go ahead. Okay. Next. What does it signify? How do you calculate? Plat minus PEEP. And it signifies the amount of pressure you generate when you put a tidal volume. That's what the driving pressure tells you. That's very, very important. I'll tell you why it is important in the next few slides. So what does it mean to you? Pressure generated for tidal volume generation. And how do you estimate compliance? Tidal volume divided by driving pressure gives you the compliance. Is the lung stiff or compliant? Okay. In a pressure controlled mode, if somebody has a fancy that you feel that pressure controlled mode has a better flow pattern, so I use, it is not very difficult. Once the PC, the pressure control level plus PEEP is equal to your P-plat, your pressure control minus your PEEP will be your driving pressure. So this is easy to do. Whenever you look at your pressure control and your PEEP, you get the P-plat, and when you minus, you get the driving pressure. That's not very difficult at all. And whenever, I'll just skip this slide. So coming to what we have understood, now we have understood the boundaries of lung protective ventilation. We have understood the boundaries. What are the boundaries? One is the plateau pressure, one is the driving pressure. We know the boundaries on which you can set the settings. So let us see how to set the settings now. These are the values. And I said, once you ascertain that the contribution of the chest wall is causing the increase in the pressure, this need not be respected. This need not be respected. You can go and have a plateau pressure of 25, 30. There is no problem. And a driving pressure of 20, 15, no problem, because we know we require that much pressure to lift your chest wall up or push your diaphragm down. So whenever you have pneumoperitoneum or you have any reverse Trendelenburg position, probably this need not be respected. So what happens under anesthesia is the next question, isn't it? Why are our patients more prone for PPCs? Because in supine position, general anesthesia with neuromuscular movement, neuromuscular blockers, there is a cephaloid movement of diaphragm, basal atelectasis is there, and also surgical issues that are pneumoperitoneum, positioning, circuit disconnection, probably reverse Trendelenburg position, sometimes even lot of mops, lot of retractors being used by the surgeons, hernia surgeries, huge hernias, when they put and stitch huge umbilical hernias, it is like putting 2 kgs into a 1 kg bag. Suddenly the diaphragm finds it difficult to go down. So all this happens during anesthesia. So atelectasis occurs and there is reduced amount of alveoli, and also you have alveoli with different time constants. So 2 things you have to remember. In anesthesia, the number of alveoli open reduces and you make lung heterogeneous, meaning that we have alveoli with different time constants or which are more stiffer, more compliant. So we have understood already that air always chooses the path of least resistance. So it is an obvious deduction when alveoli are reduced and we have a lung with different alveoli with different time constants. The one thing that you have to reduce is tidal volume. See, this is the understanding that you should have. In anesthesia, there is a reduced FRC and the alveoli collapse. And alveoli collapse because of superimposing pressure, neuromuscular blockade, and also because of the abdomen contents pushing your diaphragm up. So the basal alveoli find it difficult to open up. So the air preferentially goes and overstretches the alveoli which are compliant. So the one thing that you have to do is reduce your tidal volumes. The tidal volumes that are accepted in modern day practice is 6 to 7 ml. Max is 8. So if you take back one message from this talk, I would ask you or urge you to have a practice of tidal volume setting at 7 and between 6.5 to 7.5 should be the range where you tend to maintain your tidal volumes. And the commonest thing everybody does is whenever somebody has hypoxia, increasing FiO2. Increasing FiO2 increases your oxygenation, but it does not improve your compliance. And also it makes you less vigilant to the problems that are occurring. So you always don't increase FiO2. That is one thing the younger colleagues have to remember, that FiO2 is the last thing we increase. Maybe in a crisis situation we increase, but whenever there is a fall in SpO2, always think, can I increase my PEEP? Can I do a recruitment maneuver? Not increase the FiO2. Because by increasing the FiO2, you are not changing the compliance, meaning I am not opening up the newer alveoli. The tidal volume is again going to the compliant alveoli and pressures will go up. That's not the way to work. And prolonged usage of 100% oxygen also causes absorption atelectasis. And this also should be followed in the post-operative. The commonest thing I see is every patient in the ICU should have 100% FiO2 with 10 or 12 liters of 100% SpO2 with 10 or 12 liters of FiO2. This is a common practice. That's a very wrong thing to know. Whenever somebody has an oxygen FiO2 flow of 2 liters, if you increase it to 3 liters, you should assume or find the cause that something is happening at the alveolar level. You just increase the FiO2, then you will handle the patient only when the patient is in a collapse stage. So FiO2 is a very dangerous thing to use unjudiciously in anesthesia. That is the second point of take-home message for the postgraduates. FiO2, whenever you increase in acute crisis situation is fine. Otherwise, always play around with PEEP and recruitment maneuvers. And because of the reduced FRC, there is reduced number of alveoli to handle your FiO2, your tidal volume. Your small VT has to be done. That is the 2 take-home messages from this slide. So the first thing is reduce, and second thing is you should see the lung. You should not set the tidal volume according to weight. It should be always the predicted weight. I am very sure that none of us do the formula calculate in the pre-operative rounds. See, at least do this. You measure the patient's height, Remember this. This is a rule of thumb. It works well. I would be very happy that if you set tidal volume according to the height of the patient. And once you ascertain, set it for that. If you guess somebody's weight, it is very, very criminal. The whole purpose of lung protective ventilation goes. And looking at the driving pressure is it tells us whether the tidal volume what I am giving is appropriate to the number of alveoli I have. If the number of alveoli, if I roughly set something and if my pressure goes up, you should think that for a number of alveoli, there is overstretching that is happening. So this will cause post-pulmonary complications. That is what you have to analyze when you look at the pressures. Second is PEEP. See, PEEP is something, PEEP works like this. It increases the FRC, increases the surface area, better oxygen. See, PEEP is a de-recruiting force. It's not a recruiting force. It is a maneuver that works in the expiratory phase, not in the inspiratory phase. That is something the postgraduates miss, and it works by increasing the transpulmonary pressure. So it affects all the alveoli, both the normal alveoli and abnormal alveoli. But once you increase the FRC, there will be some alveoli which will open and close during the normal tidal ventilation. The number of alveoli doing that will be reduced. And another thing is, once the alveoli, newer alveoli open up, the surfactant monolayer spreads, the compliance improves, and also we use in pulmonary edema because it pushes the fluid to the interstitium. So for all patients, remember this, the PEEP has to be 5. And don't think it affects your tidal volume. If at all, if it affects your tidal volume, it is all because of low fluid status, maybe because of the anesthetics. A lot of vasodilatation has occurred. Your anesthetics may be contributing. Just push up some volume, but always try to ventilate all your patients with at least a PEEP of 5. Any ventilation less than 5 is not acceptable in present day practice. So then from there, you have to take it forward and do it in an individualized manner. See, somebody goes into a pneumoperitoneum, the SpO2 falls. I would increase my PEEP to 8, 9, 10, 11, 12. I don't mind increasing my PEEP because I know my diaphragm is not going down. So that is how you individualize. Or you see a very obese lady, probably the chest is not easy to lift up. So then you require more PEEP and more FRC. So the SpO2s are better. So to visually understand how PEEP works, we want to have a ventilation from here to here. We don't want the lung to collapse or over distend. So this framework can be got by looking at your plateau pressures and driving pressures. If you keep your plateau pressures less than 16 and your driving pressures less than 13, your lung will be ventilating from this part to this part, from this part to this part. We don't want the lung without PEEP. The lung ventilates here, then goes here and goes here. This is what we call as atelectotrauma. A cyclical opening and closing causing atelectotrauma and over distension. We don't want these two to happen. We want ventilation to happen here. This happens only with application of PEEP, not with the tidal volume. Should remember that because it's a de-recruiting force. PEEP is a de-recruiting force. So recruitment maneuver is a sustained increase in airway pressure with a goal to open collapsed lung tissue, after which we apply sufficient PEEP to keep it open. The whole idea is the amount of pressure. See, if you think that by putting high pressure for a very short time, you open up. Because the surfactant monolayer spreads and it becomes more compliant. So once you open up, you don't require the same pressure to keep it open. Probably a PEEP of baseline of 10, if you add up another 2, those kind of a sustained small increase in pressure for a few seconds has made more alveoli open. And now that keeping it open is much easier. So that is how the recruitment maneuver works. But the thing is, you have to understand here also, air always chooses the path of least resistance. It is going to go and over distend your normal alveoli. That is the reason you have to do only when your PEEP doesn't work, do a recruitment maneuver. Don't do recruitment maneuver for every patient. You have to manage it with PEEP, or in any acute deterioration, probably you can do a recruitment maneuver. Otherwise, always play around with PEEP. When PEEP doesn't work, you go and apply a recruitment maneuver. And as I've said, you have to increase your PEEP. Otherwise, the alveoli that you have opened up again collapse. A lot of critical care ARDS studies have shown that it happens so. So if your baseline is 8, do a recruitment, you always increase your P by 2. So keep it at 10. Otherwise, the work of the recruitment maneuver that worked for a few seconds is not going to continue showing a similar result in a longer time frame. These are some of the contraindications. It's quite obvious. So you should not do recruitment maneuvers in these situations. And whenever you do a recruitment maneuver, as I've said, it always hits the normal alveoli. But we do it because no maneuver is working. So we do it. So obviously, two things are obvious. It should be obvious at this level to all the postgraduates that it has to be done only when your PEEP works. And because it affects your normal alveoli, it has to be done only for a short duration. You cannot do recruitment maneuver every 5 minutes or 10 minutes. It doesn't. It injures your normal alveoli. You can do it only when it doesn't work. So the easiest way to do is, and as I've said, always watch your hemodynamics. When you do a recruitment maneuver, if you don't look at your hemodynamics, you may improve your oxygenation, but delivery of oxygen to the mitochondria doesn't happen. So that's the guideline that the consensus committee produced. They have not recommended because for the obvious reason that it is going to affect your hemodynamics, it is going to affect your normal alveoli. You do it only when PEEP doesn't work. And manual squeezing is not being advised because it is a 2-liter bag. And I've seen the younger colleagues, they get excited when the saturation falls, they'll be pumping in 2 liters for every tidal volume. The lung will blow out. And beyond the lung, the heart doesn't pump any blood in that situation. If you give it to a nurse, you can be rest assured that she'll pump in 2 liters or 1 liter. If you give a 1 liter bag, 1 liter will become your tidal volume. So the easiest ARM that we practice in critical care is just go to a pressure controlled mode, increase the pressure control to 40 if it is a kind of a only lung situation. If it is a obese or a chest condition, you can go up to 50, 60 centimeters, a PEEP of 15 centimeters. Whatever the PEEP we have set, forget it. You set a PEEP of 15 centimeters, a pressure control of 40, 50 or 60, depending upon the patient's situation. It is only for 42 seconds. Most of the ventilators, anesthesia ventilators, modern anesthesia workstations have a button called recruitment maneuver. You can just press the recruitment maneuver. This is what happens. And after 44 seconds, it comes back to the original tidal volume settings. The only thing what you have to do is, if your tidal volume setting is say 10 centimeters, add up 2 centimeters there. Because the lung is not going to be open for a long time without increasing the PEEP. And there are lot many methods of altering, but with my 30 years experience, I would say this requires a lot of time and patience. I'm very sure that even in the ICU, my registers also won't do this. If I ask them to keep on increasing, wait for 4 breaths, then look at your hemodynamics, look at this, that, it's not going to happen. So there is no studies saying that one is better over the other. For beginners and postgraduates, a sustained inflation is what is very successful, easy to implement. So I would suggest that the postgraduates learn one method. Once you become very convenient doing these things, probably you can try the other methods out. And in fact, some buttons also have a side. That also is a recruitment maneuver. The pressure suddenly goes up for a while, large tidal volume is delivered, and again it comes back to the normal tidal setting. But whenever you do a side and see an increase in the SpO2, decrease in the EtCO2, probably your PEEP has to go +2 from the baseline. That is something you have to remember. This is what it means. It has to be individualized afterwards. See, which mode is better? The committee says that there is no specific recommendation, but as an anesthesiologist and looking at the way of ease of doing plateau pressures, I would urge the beginners to ventilate most of the patients in volume control because plateau pressure measurement becomes easy. And in the Las Vegas study also, 70% worldwide anesthesiologists were using volume controlled in anesthesia practice. So no mode is definitely safer. It is the settings that we set limits, the place, the alarm limits that we place, like knowing that your plateau pressure should not be more than 16, 17, driving pressure should not be more than 13. That is the alarm. And whenever changes occurs, so how you manage is what makes a mode safer. Just by putting a mode, it doesn't work safer. There has been no recommendations on IE ratio, but 1:2 is good. There has been no recommendation for respiratory rate also. Anywhere between 12 to 20 should be fine. A normal, most of the anesthetists try to increase the respiratory rate to a normal PCO2. And for younger generation anesthesiologists, normal is always 35. Why do you want to push the carbon dioxide so low? Because during reversal, during recovery, emergence, everything becomes difficult. So carbon dioxide should be around 41, 42. See, to push it down, you are putting more minute ventilation. If you put more minute ventilation into the lung, and if you want a saturation of 99 to every patient, you can achieve it, but you will have more PPCs. That is what you have to target. So induction, there are few guidelines that they have quoted. So on a head elevated 30 degrees, and to avoid flat supine position. If not contraindicated, they say that you can apply a CPAP, a PEEP of about 10 when somebody is in a spontaneous respiratory thing. And then you can put a nasopharyngeal airway if there is an obstruction. And after intubation, it is always better to work with a FiO2 of 0.4 and work more with PEEP and recruitment maneuvers rather than increasing FiO2. Three things, oxygen toxicity, absorption atelectasis, and you always don't pick up the deterioration. That is something you have to remember whenever you increase the FiO2. So emergence, again, using less FiO2. And another thing commonly people do is to build up from 35 carbon dioxide, they cut down the PEEP and stop the ventilation. That's the worst thing you can do as an anesthesiologist. You should never ever cut down the PEEP to 0 and bring up the carbon dioxide, because we all know that carbon dioxide is a very, very aggressive stimulant of the respiratory system. That's not, but that leads to the maximum PPCs. In fact, if you use a FiO2 of 0.8%, they say after extubation, you put up some PEEP on a patient to prevent atelectasis. And when you suck, you always remember, you don't remove only secretions, you also remove air. So your lungs collapse. So before extubation, always go on to a pressure support, increase the PEEP to 10 to 12 centimeters for 3 minutes so that the atelectasis is gauze, and then you can extubate. Another common way of looking whether your patient is fit for extubation is always ask him to cough 3 times. If your peak cough expiratory flows are more than 60, probably you can extubate. These are some things, minor things, which really makes a difference in a major surgery, where putting after suction, see, when you suck, you don't generally suck secretions, you also suck air out, isn't it? All the air comes, the lung collapses. And suddenly you see the saturation drops. Then wait patiently, put him on a pressure control. Even a volume control or a pressure control doesn't matter. You wait for 1 or 2 minutes, let him breathe nicely, let all the alveoli open. Then on a slightly head up position, you can extubate the patient. Post-operatively, a lot of issues are there like pain, bed rest, opioids. So here, a integrated multidisciplinary protocol is what is required. So a lot of physiotherapists, intensivists, everything has to be coordinated. And you can use NIV and CPAP or HFNO if somebody was on that previously. And you don't require to give everybody oxygen, remember that. And whenever you give oxygen, give minimum oxygen. Whenever you increase oxygen, you think what is happening at the alveolar level. If you just look at your SpO2 and try to ventilate patients, you will get into trouble. So how do you start mechanical ventilation intraoperatively? This is something important. Always measure height or predictive body weight. Induction during less than FiO2 40%, CPAP, I would go with volume controlled ventilation. My target is SpO2 of more than 94%. Then I set what should be the tidal volume. Can anybody type? What should be the starting PEEP? What should be the starting IE ratio, respiratory rate? Then you get PIP. It is already there on the ventilator. Then you should put an inspiratory hold, look at the PEEP plat, driving pressure, and then only the position change or pneumoperitoneum occurs. If you don't do this, then you don't know for what reason the pressure is going up or down. So this is what you have to do for every patient. It has to be a chart like this for every patient who is ventilated under general anesthesia. Then, whenever you increase the PEEP or do a recruitment maneuver, again recheck the plateau and drain pressure and your compliance. If you don't see, if something is happening not the way you anticipated, then you should know that you are not opening new alveoli, you are overstretching the already compliant alveoli. Then this doesn't work. Then you have to think differently. And always, and whenever you see any change in SpO2 and DTO2, go back to your ventilator and look at your plateau pressures. What was the previous plateau pressures? What has it changed now? And always keep a watch on the hemodynamics. And another common mistake I've seen most of the younger colleagues of mine doing is, see, there is something called a pressure relief valve in all ventilators, modern day. See, if you have set it at say 30, and if you intubate somebody and he goes into a bronchospasm and he starts developing a pressure of 45, 50, then the air doesn't go to the lung. It starts venting out. And I've seen patients, my colleagues changing 4 or 5 ventilators. They would have rotated all the ventilators. Somebody will be ambuing and all ventilators. The only thing that you have to do is set the Pmax setting higher. We set it 10 above the PIP. We normally under anesthesia, our PIP range would be around 20. So we would set it at 30. But in an asthmatic, because of the airway pressure, if it goes beyond 30, the air comes out, doesn't go into the lung. So in that situation, this has to be done. Remember this. This is common mistake I've seen over time. So another thing you have to understand is height is what matters, not the weight. The lung size doesn't differ because somebody is obese. Lung size doesn't differ. So this is the formula. And then 2 is PEEP, personalized. These are the boundaries. And PEEP in an obese lady can be around 17 to 12, or a man can be 17 to 12, it doesn't matter. Recruitment maneuver, only when PEEP doesn't work. No ambuing, and high FiO2 without PEEP may not prevent atelectasis. The last slide is, don't forget clinical examination. Don't think all your monitors is going to give information. I have seen, and in present day, most of the anesthetists don't even wear a stethoscope. This is what is happening because they think gadgets will help. Always see the chest, hear the chest. I'm telling you, it gives a lot of information. Then is ventilatory parameters. Then is ETCO2 and SpO2. ETCO2 is a very, very good monitor because it gives you information on ventilation, circulation, and metabolism. If you want, in one of the classes, I can integrate how to manage your patients, looking at your ETCO2 and any, any alterations that alterations around anesthesia, looking at your SpO2, intra-arterial pressures, and ETCO2. If Dr. Johnson gives me more lecture sometime after a few months, I'll present a talk to you how useful is ETCO2. ETCO2 should be the bread and butter for an anesthesiologist. If you somebody gives a choice between SpO2 and ETCO2, always pick up a ETCO2. It gives more information. So clinical examination, ventilator parameters, then the other things. So always remember the order. Then as we are looking at the transesophageal, transthoracic, ultrasound, ABG comes next. Okay. So if time permits, I have 3 case scenarios. If Dr. Johnson has time and if the students are still keen to learn.
No, sir, you go ahead. You can go ahead.
Okay. Just 5-10 minutes.
Okay.
See, peak pressure started showing 42 centimeters. So what do you do? And the patient is getting desaturated. How do you proceed? Can anybody type? What is the first thing you look at and do? What do you look at? Can somebody type? See, now patient is getting desaturated. Increase the Pmax. To how much? I would, no. First is increase the Pmax, then only you can look at the P plat because no air is getting in. Air is going out, it's getting vented. So I would definitely go up to 60, Pmax of 60. I don't have a problem because I know. Now, then look at the plateau. In plateau pressure, what do you expect? What will be the, what do you expect in the plateau pressure? It will be more, less. What will be the difference between PIP and plateau? Yeah. The trans airway pressure will be high. The plateau pressure will be normal. Then absolutely you know it is because of the bronchospasm. You should not get tensed in such situation. You increase the peak flows. You increase the... Wait. I'll come back. Okay. This is what you will see. So you know that it is a spasm. So how do you treat? I am very much sure most of the postgraduates are going to, if somebody sees a carbon dioxide of 75, I am 100% sure that every postgraduate will increase the respiratory rate and tidal volume. And if you do a ABG after 1 hour, carbon dioxide will be 100. Take my word. When I do the ARDS and COPD talk, I will show you how to manage. And this is how you manage. You should reduce the tidal volume and respiratory rate. It may look counterintuitive because we have been taught carbon dioxide is inversely proportional to minute ventilation. It is a wrong statement. Carbon dioxide is inversely proportional to alveolar ventilation. We discount the dead space. And we get into problem. The best thing you can do is cut down the tidal volume, cut down the respiratory rate, and increase the IE ratio to 1:4. Let us not get into that. So you ascertain what is the problem. That is what I wanted. See, after 2 hours, the peak pressure has become 32 and the peak pressure has again fallen down to 21. So you know the spasm has gone, isn't it? This is how you do. Just look at the parameters now. So, obese, do you start with 10 PEEP? Probably I would start with 10 PEEP if the pressures are all right, if she's hemodynamically comfortable. If not comfortable also, I would push in volume and start with a PEEP of 10. Then, after induction, insufflation, SpO2 drops to 84, carbon dioxide goes up a little, BP drops to 80, 50, your PIP has gone to 35, plateau has gone to 28, the driving pressure has gone to 18. What is your inference? Is it a lung issue or is it a airway issue? Yes or no? Is it a lung issue? Is it a chest wall issue? Only 3 questions. What is the issue now? Can somebody type? Yes, chest wall. Yes, absolutely chest wall. So how do you do now? What do you do? It goes to 80. See, we are always thinking what to do. Why don't we say, hold back the surgery, ask the surgeon to deflate? It's the easiest thing to do, isn't it? We always try to do on our own. But whenever they start bleeding, because of a major artery cut also, the surgeon calls up and says, something is wrong, I'm bleeding more. This is the obvious thing that happens all the time, isn't it? The thing here, I would ask the surgeon to reduce pneumoperitoneum, fluid load the patient, start a small dose of noradrenaline, then I would increase the PEEP. This is what you have to think as an anesthetist. Don't think everything can be done at our side. The patient is in their surgeon's hand. And most of the times, they think that we don't manage it well, isn't it? Most of the surgeons, especially gynecologists, works on the premise. That way, isn't it? So this is how the recruitment has to be done. And I've said this is the easiest one. For beginners, always do this. And if in your ventilator, if there is a recruitment maneuver, there is a button called recruitment maneuvers in anesthesia GE workstation. You just have to press the button. This is what happens and it goes back. The only thing what you have to do is increase the PEEP from the baseline. You have intubated patient, you look at the patient, peak pressure was 32. Then plateau was this much. So what is the problem? Lung or the chest wall? It is the lung, isn't it? Now, the management would be, what is the primary cause for the lung getting more non-compliant? What is the primary pathology here? Is it because of some lung pathology or something else outside? like a lung. So, as my previous speaker has taught you, now what should be your management now? So, I see I have combined both the talks now. What should be the? Do you go ahead and give fluid? Diuretics? Then the blood pressures are maybe 80/50. Which inotrope would you use? Which inotrope or a vasopressor? Okay, fair enough. And you can increase the PEEP once the pressure stabilizes. I would not go with adrenaline. I would go with noradrenaline and dopamine and noradrenaline. Because of it's a inodilator, I would start with a noradrenaline. Even in a cardiogenic shock, the first drug of choice is noradrenaline. Remember this. Then only we add an inotrope. Vasopressor first, whenever blood pressure is low for us in anesthesia, always norad. Once it reaches 0.2, 0.3, you add up a vasopressin or adrenaline. Then you add the third one. Because it's a cardiac, you can go with noradrenaline and dobutamine. Peak is 33, plateau is 30. So patient has probably developed some amount of pulmonary edema or a trolley, isn't it? Massive transfusion. So you can increase the PEEP, you can do a recruitment maneuver, always looking at the hemodynamics. You understand how to manipulate and how to check, always peak, plateau, driving pressure. Then only the whole thing moves. RM only if the PEEP doesn't work, sudden decrease in SpO2, sometimes very, very low, circuit break, position change, gas in abdomen. Always put back, change the position back, reassess, fill the fluid, stabilize hemodynamics, then go back. Don't think that surgeon will feel awkward. We are not obliged to the surgeon, we are obliged to the patient. Every anesthetist should understand that we are not obliged to the surgeon, we are obliged to our patients. Thank you, sir. Thank you. I think I overshot by 5-10 minutes.
No
so
problem.
Kindly excuse me. Kindly excuse me.
Rajesh, sir.
Yeah.
It's difficult to search the questions in the chat box. Already more answers.
Already every question has been answered.
Okay,
sir, you have taken up all the questions, sir. So I think we can end the session. Thank you, sir. Thank you for the excellent talk, sir. Thanks, and over to Edward, sir.
Excellent presentation, sir. We are not seeing so much of physiology combined intraoperative ventilation presentation. We are not seen anywhere, sir. It is looking the ventilation through the prism of physiology of alveoli. So we have to go through your presentation once more to understand more.
So you can give it to all delegates, sir.
You already sent your presentation to me. I will forward it to my participants. Thank you very much, sir. So we are looking forward. You already said that ETCO2 and ventilation in the intraoperative period correlation.
Yes, sir.
We will have one more class regarding that, sir. Thank you very much, sir. We are looking forward to very interesting lectures in the coming weeks, sir. Thank you. Thank you so much, sir.
Thank you, sir.
Thank you, Rajesh, sir. Thank you. Thank you, one and all. I thank the previous speaker also, and also I thank the A1 Logics, the Anaesthesia TV, and our Acrola, that is the sponsor. Thank you very much. We will meet the next week. Thank you, sir. Thank you, Rajesh.
Thank you, sir.
Thank you.
We will wind up.